because 21 ppm is what you and I are currently using at the moment. If somebody is on oxygen, they might say, okay, 35% FiO2, and they might say maybe 80% FiO2. If that makes sense. So you're going to see a bunch of information, but for now, keep it simple. What have I said up to now? You're going to see printout that looks like this. Do you want to confirm the patient identity on it? Do you want to confirm? And again, if they've done, maybe, let's say, I've been seen this patient before. I saw them last week, 2 weeks ago or so, or thereabout. They had the ABGs. Now today they had another ABGs. Do I want to look at the ABGs they've done in the past, look at the readings and correlate that with the current ABGs I'm having? Just like if you had somebody to go to run X-ray, for instance, you want to compare the recent one they've done with the previous one they've done, if that makes sense to you guys. And again, aside from that, put your readings, like I said when I was doing the teaching on blood, on all of those things, like I mentioned to you guys, every reading or every scan or every blood or every text you're asking a patient to do, every text must be put in the context of your patient. It won't make sense if you are making ABG interpretations and this is patient dying, or this is patient even comfy, and you are just doing your paper reading, this is, and you are not even, relating that particular thing to your patient care. It won't make sense. It won't make sense at all. So what have we said? I know why I'm repeating because these are a bunch of informations that, it's really, it's always a burden. It's always a struggle for everyone. I remember back in the days in school as well, but everyone keeps struggling with all of these things. But like I mentioned, I will try to be very slow and keep it basic so that we can understand the context. So what have I said up to this level? ABGs, you're going to see printout that looks like this. You're going to see a bunch of information on it. You want to confirm the patient identity. If they've done ABG in the past, do you want to correlate the two together? Or the new one with the previous one? Do you want to relate that particular ABG? Then put that in the context of your patient. That is very, very important. Let's crack on. So again, this slide is just showing what I just explained. You're going to find a bunch of information about acid-base status, like pH, CO2, oxygen, base excess, bicarb. You're going to find those things there. And again, depending on the unit, there are different categorizations you might find as well. That depends on where you work. Sometimes, generally, most hospitals you might find kilopascals, and sometimes you might also find millimeter of mercury. It's just the same clinical reasonings. The way you would normally reason, if, let's say for instance, now in my hospital, we use kilopascal now, and your hospital you use millimeter mercury. Nothing change, nothing significant. All you just need to do is just look at the range, make your interpretation, then put it in the context of the patient. Okay, it's still the same clinical reasons will still apply to your patient, if that makes sense. Then, so different informations, you're going to find anion gap, you're going to find electrolyte, you lot of informations. But let's start driving in gradually. Now, I showed this slide yesterday as well, for some of us that are here, that when it comes to ABG readings, of course, physios will not be the one going at the bedside, trying to bleed the patient to take their blood and all of those things. These are stuff you'll find medical team doing, nursing team. Yeah, where work, if I need ABG reading, I'll just do my stuff with the patient. I'll ask the nurse, do ABG for me in maybe half an hour, 1 hour, depending on my patient context. So, of course, and again, it will make sense to you as a physio to know where those bloods will also be taken. Yeah, blood could be taken in the arm, arteries in the arm, your radial arteries. It could be taken, let's say, for instance, generally speaking, people will normally take blood from the radial artery. Maybe by any reasons they are struggling to bleed the patient, or they are struggling to take blood from there. You might find blood being taken elsewhere in the body. It could be through the femoral artery, it could be brachial arteries, it could even be through the ulnar arteries. So just be aware. Just be aware of some of these basic things. Anyways, so let's move on. So now, why are we so concerned about these ABGs of a thing? Why are we here? Why are we teaching these things? Or why are we having training on these things? The major goal is just to know how our body biomechanics or our body biological system, how they work. And the way our body work, all activities in our body, they like to work in their neutral environment. They like to work in their standard and stable environment. So, and what that means is about the concept about homeostasis is just about balance, making things to be balanced. Just like if you remember our basic secondary school, our chemistry, they will say when you have acid for neutralization reaction, when you've got acid, there must be a base that will neutralize each other. So you don't want your environment, your body does not like the environment to be too toxic. Being too toxic means you don't want it to be too acid and you don't want it to be too basic. So nature has actually made this thing in a way that there will always be something that will keep checkmating our biological system. We don't want things to be go too toxic. You always want things to be nice and well controlled. So now, for the sake of these ABGs, of course, we have a lot of mechanisms in our body that can run these hemostasis for us. But for the sake of these ABG readings, always remember your respiratory system and remember your renal system. These are two big systems that are much more directly related with regulations of our biological system. Your renal system and your respiratory system. Which one work fast? We're going to see. When does respiratory kick in? When does renal kick in? We're going to see. But for now, all I want you to remember here in this particular slide is remember our body like to work in a stable environment. What is that stable environment? Let's look at this next slide here. So the stable environment here is the neutral environment. What is that neutral environment? It's just the pH here. What is pH? pH talks about the degree of acidity that you've got. If you look at the equation here, like I mentioned, there's no way you're going to change this topic and you won't have to bring up some of those equations we've been taught in our past secondary school days. But I'll try to simplify it and just pick those stuff that are very inclined with physio. So now, if you look at this equation here, it's just negative log of hydrogen ions. So that means the major driver of our pH, of our environment, of our biological environment is just the hydrogen ion. If the hydrogen ion is too much, what does that mean? You're going to have to start having things like, the environment will start getting acidic. That's what that means. And what happened to pH? What is this negative log here? What is this negative log? What is it doing here? Why is it coming from? I'm not going to discuss that. But what you just need to remember here is just telling you that the relationship between hydrogen and pH here is like an inverse relation. If that makes sense to somebody. Meaning, if you've got a very huge amount of hydrogen in your blood, what's going to happen to pH? The pH will start dropping. That's what it means. And again, if you've got, let's say you've lost a lot of hydrogen ions due to some reasons in your body, we're going to discuss those reasons. If you've lost some hydrogen ion in your body, what is going to happen to your pH? Your pH will start going higher. But again, remember, our biological system does not like to work in a toxic environment. They don't like that very, very severe acidic environment, and they do not like that very severe alkaline or basic environment. They like to work at a pH of 7.35 to 7.45. 7, everything 7, pH 7. What that means, what does that mean to you as a physio? That means no matter how poorly a patient is in the hospital, no matter how sick they are, no matter how dying they are, it is unlikely that you're going to see a pH of 15. You're not going to see that. That person will not be compatible with life. If that makes sense to you as a physio, you're not going to see somebody with a pH of 2, 3. The person will not be compatible with life. They are dead already. If that makes sense. So what that means again is, as a physio, I am repeating again, our biological system like to work between 7.35 to 7.45. So for any reasons, if our biology system start retaining hydrogen, we start having a lot of hydrogens, what is going to happen? Buffering system will start happening in order to regulate that hydrogen to bring the pH back to normal. That's how it works. We're going to see how those regulations happen. But again, remember, the whole bunch of your biological system, the enzymatic reaction that happens in your body, your proteins in your body, the electrical activities, everything that happens in your body, they like to work between the pH of 7.35 to 7.45. Again, do we have to cram that? We have to commit that to brain? The answer to that is no. because most of the ABG readings, again, depending on where you work, you might find the readings there. And again, the more you see poorly patient, ITU patient, or patient on the ward, they have chance to retain CO2, they are running their ABGs. The more you see those patients, the more some of these values will start sticking, to your head. So, but for now, just remember, pH of 7 is what your body likes to work. You're not going to see somebody of pH of 2, 1, 0. You're not going to see somebody of pH of 15, 20, 30. They are not compatible with life. All right. Please, am I making sense? Is it making sense? Or am I too fast? Or what do you think? Response. Hello? Hello, guys.
You're making sense, sir.
You're
Right
cool.
on, sir.
Okay. All right.
You are doing great.
Thank you very much. Thank you very much for that feedback. All right, let's move forward. So, okay, yeah, this is another very, 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 I would say, equations. My goal for putting this slide is just to familiarize us with some basic concept, very, very basic concept. I'm not going to sit down here and start speaking hell of biochemical reactions and no. What I will just do with this slide is just to get us familiarized. I'm sorry, don't be afraid. I'm going to keep it simple. No panic. I'm going to keep it very simple. All we just need to remember, I'm going to let us know. Now, CO2, generally, everyone knows at the moment, we are all comfortable. We are all listening to me. I'm also speaking at the same time. Nobody's in any respiratory distress. What are we doing at the moment? We are doing normal tidal breathing, normal respiratory breathing, normal breathing, comfortable. The diaphragm is going down, is going up, all those kind of things. What we are doing is we are taking in oxygen and we are breathing out CO2. Everyone knows that the oxygen that we are breathing in is just from the environment. How about the CO2? Where is it coming from? What makes the CO2? I think it will make sense, because if you've got a poorly patient on bed, they are being poorly, they are dying, they are needing to be on huge amount of oxygen, like 60, like 70, like 80. Even some will even be at in 100% oxygen. Let's say in the ITU, of course, you're not going to see somebody like that on the ward. Let's say in the ITU. So it's going to make sense to you if we begin to understand where is the CO2, all of the CO2, where are they coming from? So now, where is the CO2 coming from? We all know that when we breathe in oxygen and when we heat, the food we eat, those food, they go to our GI system, they go into the liver, from the liver, they find their way into the cell. So when they enter our cell, the air that we breathe in, they go into the alveoli, they enter the bloodstream, they find their way, they bind with hemoglobin. We have taught oxygen, yeah. So they bind with hemoglobin. From there, they find their way into the cell as well. Oxygen and food you are eating, glucose, they are entering into the cell, they are in the cell. What is their business? Their husband and wife, they love each other. Why are they in the cell? So their purpose is just to release energy to the body. That is the major reason why we are eating. And one of the reasons why you are breathing in oxygen as well is just get the oxygen to the cell, combine them with glucose, release ATP, release energy. And again, one of the byproducts of that energy is this CO2 we are seeing here. If you look at the equation, this is what, if you look at my arrow here, if you look onto your screen, this is what I just explained. Glucose combined with oxygen, they release CO2. That is where this glucose is coming from. And sometimes, maybe by any reasons in your body, you can also find glucose not using oxygen, and they start breaking down. And they can also release CO2 as well. Remember your biology in secondary school, aerobic respiration, anaerobic. If you are using oxygen, that's aerobic. If you are not using oxygen, that's anaerobic. I think these are stuff that are related with physio as well. Don't worry, I'm going to connect them back to physio. But for now, let's go nice and gently. Now, having known that, we know now that the CO2, they are coming from the cell. So at rest, right now, you and I, in every minute, our biological system keep releasing about 200, I think between 200, 250, I think between 200 to 250 ml of CO2 into your bloodstream. That's what it means. right now, the muscles in your leg, all the muscles in your bodies, the cells in your body, the peripheral muscles and everything, they are right now releasing about 250 mils of CO2 into your bloodstream. Now, if you come back to the picture I put here, what does this picture does? You can see the CO2 now, they are coming, of course, energy has been released to this cell, CO2 is now released. So this CO2 here, this is the blood here. If you look at my arrow, please, everyone, please look onto your screen now, because we need these things to understand our physio concept as well. So now, this is, where's my arrow? Yeah, this is the red blood cell here. This is the blood here. This is the cell. So this CO2 here, they just complete, this CO2 here is a product of metabolic reactions now. Breaking down of food, CO2 has come out. From this CO2 here, this CO2 can diffuse from this cell now into the plasma. Now, again, when I was teaching blood, I mentioned something about blood, that generally we have plasma. Our blood is divided into two. We've got plasma and we've got blood cell. Plasma is just like the fluid content. Now, when CO2 leaves the cell, it's going to dissolve, it's going to diffuse into the plasma. So that plasma CO2 is what you are checking on your ABG, if that makes sense to somebody. It's as simple as that. PCO2, when you see PCO2, you already know that is the CO2 that is being dissolved in the plasma. Now, look at it, because I mentioned that right now, and every minute, our body keeps producing about 250 mL of CO2. That means some of them, we even leave the plasma. Some of them will diffuse into the blood cell, into the red blood cell. They are coming directly into the red blood cell. Yeah. Now, once they enter into the red blood cell, what happens is, of course, in the red blood cell, now, it's very easy. Let me just say this, because I'm going to connect them back to physio. But for now, just believe me, it's very easy for CO2 to start diffusing in and out of the cell. Why? What's the reason for that? Don't forget, your cell membranes is just lipid soluble. CO2, so CO2 can easily just diffuse in and out of the cell, even more than oxygen level. I'm going to tell you why that is so and what is the relation of that to physio. I'm going to discuss that later. But for now, just believe me, CO2 will diffuse from the cell. Where's my cursor? They enter into the plasma. From the plasma, they enter into the red blood cell. And once they enter into the red blood cell, what happens to them? They can combine with water. There is a particular enzyme in your red blood cell, carbonic anhydrase. These are enzymes that are already in your red blood cell waiting for CO2 to combine with water. Just remember, these are enzymes that are fixing CO2 and water together. But when they combine them together, they're going to generate carbonic acid, H2CO3. This is a very, very unstable acid. H2CO3 will just dissociate. This enzyme again, you need a lot of them to dissociate, to break down. This enzyme again will be very active in breaking down bicarbonic acid. They're going to break them down into hydrogen ions, protons, and this bicarb here, bicarbonate, bicarb. I love to call them bicarb. So forgive me for that. Hydrogen ion and bicarb. Now, this hydrogen ion here, this hydrogen ion that is being generated here, it is what actually determines the pH of your body. It is what actually determines the pH of my body and that lady on that bed. If that makes sense. So if now, let's say now, for any reasons now, we've got huge lot of our cells in our body now, they are for no reason, they are making huge amount of CO2. Or let's say we've got a patient now, they are breathing very, very slowly. Their breathing is very, very low. Let's say it could be maybe they are being overdosed on opioids like morphines, like oxycodone or anything, or maybe you've got a COPD patient that they've got a big chest, they are struggling to empty their lungs. So what happens is that same CO2 again is going to dissolve in the plasma, and from the plasma, some of them will also leave the plasma and also diffuse into the red blood cell. And you've got an enzyme. You don't even need to remember the name of the enzyme. An enzyme in the plasma that keeps fixing CO2 and water together, they keep generating hydrogen ion, and bicarbonate. Now, that hydrogen ion, if it's too much in your blood, what is going to happen? The pH will start changing. Don't forget the least pH, the pH you want your body to be is within 7.25, 7.35, 7.35, 7.45. If it's too much, the pH will start going down. It's not making sense. So we need some system to be able to rectify that pH, to be able to bring down the pH if it's too much. So remember, there are some monkeys. That was what the analogy I was trying to use yesterday. There are some monkeys in our biological system. What they do is just to checkmate. I think that is. I think we are having some. We're having some interference. I don't know. Hello, sir. Can we get the person to be mute, please? All right. So now, there are some monkeys in our biological system. All they do is just to regulate the amount of hydrogen ions. Don't forget, hydrogen ions decide what your pH is going to be, what the environment of your body is going to be. So remember, two buffering system here, but one is very, very important. Even if you don't remember the second one, remember one. One of them is that bicarb, that HCO3. Is the largest buffering system in our body. If the hydrogen ion is too much in your blood, what is going to happen? The bicarb, they will start picking up the hydrogen ion. They will start mopping them up. They will start. How do they mop them up? They combine with them to form CO2 and pop them out. I'm going to bring another, but for now, just believe that. If that makes sense to you. And again, let's say for no reasons, you've got less amount of hydrogen ion in your blood. What is going to happen? So again, the buffering system again can combine with hydrogen again to start making, so the equation can go back, start making CO2s and all of those things, if that makes sense. Okay, don't let me complicate these things. What do you have to remember here? Two things for now. Your cell make CO2. It's as simple as that. Now, the CO2 that your body makes, see, this CO2 decide indirectly or directly what the pH of your body is going to be. So the pH is making the hydrogen, and CO2 is making the hydrogen, and the CO2 is also making the bicarb. If that makes sense to us. Now, if the hydrogen is too much in your body, you need a monkey. Get them out. Get the hydrogen ions that are too much, to mop them out, get rid of them. You need bicarb. That is the role of bicarb here. So what that means is, in your blood right now, in my blood right now, we've got some bicarb, some monkeys that are just floating around in our blood, that are just moving around in our blood. What are they trying to do in our blood? They're trying to look for hydrogen ions that are too much, to catch them, to remove them. Because if the hydrogen ions are too much, the pH will start dropping down, if that makes sense. And again, if these monkeys, again, at the same time, if the monkey are also too much in the blood, if the bicarb are also too much in the blood, what does that mean again? We need to get rid of them. Now, maybe additional stuff here. CO2 generally, CO2 are just being transmitted in our biological system in three ways. If you come down to this equation, let's say normal person now, you and I, normally, no respiratory distress, no concern, no chest concern, no infections. Everyone is all right. Our cell, my muscle in my hand now, they release CO2. CO2 will go into the plasma. From the plasma, they enter into my red blood cell. When they enter into my red blood cell, the enzyme in the red blood cell, they combine CO2 and water together. That will generate hydrogen ion and bicarb. Now, the bicarb, because there is no reason for them to stay on my red blood cell. There is no reason, because the pH in my blood is fine. There's no reason for them to stay on my red blood cell. So they need to leave. They will diffuse out. They will come out to the plasma. They will come out. If you look at this thing again, chlorides, these are all those bunch of information that are written on that ABG, that initial printout that I showed you. These are where some of them are coming from. If you on that list, you also find chloride as well. This is where the chloride is also coming from, because chloride also has relation to ABGs as well, with your blood system as well. Now, because again, like I mentioned, there is no reason for that monkey to be staying in my blood, because my pH of my blood is fine. What will happen to the monkey? The monkey will go back to the plasma. Now, you don't want to turn my plasma now, you don't want to turn them to a bunch of monkeys. So what will happen? So you need to throw, because those monkeys are negative. They are negative. They are negative. They are negative ions. So if I keep retaining a lot of monkeys, a lot of bicarb in my plasma, it's going to turn to bag of negative salts. You don't want that to happen. So what is going to happen is, so if you throw out bicarb, you're going to throw in chlorine. If you throw out bicarb, you're going to throw in chlorine, because you want to balance everything. Again, if you remember, when I was teaching electrolytes under blood, was it blood? Yes. When I was teaching that under blood, I mentioned about sodium and potassium. One is inside, one is outside. If one goes out, the other one comes in. Same thing happens here. I will stop this one for now here. There are still a lot of things I still have to discuss. Maybe if we have the time, I'll come back to these things. What do we have to remember? Let's go back. Let's move forward for now. Look at this equation here, because I don't want to complicate these things. I've promised you guys I will do my bit to keep it very, very simple, very basic. We know where this CO2 is coming from. Where's my cursor? We know where this CO2 is coming from. They are coming from the cell. Now, CO2 is in the plasma now. I'm sorry, it's in the blood now. It's in the red blood cell now. They dissolve with water. They generate bicarb and they generate hydrogen ion. Even if you don't remember all I said in that previous slide, remember what I'm going to discuss here. So they generate hydrogen ion and bicarb. Now, this hydrogen ion here decides what is going to happen to your pH. If the hydrogen ion are too plenty in the blood, what is going to happen to pH? The pH will start dropping. If the hydrogen ion are scanty in the blood for no reasons, they are scanty in the blood, what is going to happen to the pH? pH will start going high. If that makes sense, again, if that is difficult to remember the equation. pH is negative log of hydrogen, which means hydrogen and pH are inversely proportional. If hydrogen is going up, pH will be dropping. Sorry, if hydrogen is going up, if you are retaining more hydrogen, the pH will be dropping down. So if you are losing a lot of hydrogen, the pH will be going up. If that makes sense to you. Again, let's make it clinical now. Let's say we've got a patient. They have chest deformity, they have, let's say spinal deformity, let's say kyphoscoliosis, or you've got an obese patient on the ward. They breathe very, very less because their diaphragm, because of the fat in their tummy, their diaphragm are struggling to descend. Or let's say you've got a post-op patient, laparoscopy patient, they've got oesophageectomy, they've done Whipple surgeries, they've got anterior recessions, or you've got the one we are very familiar with. We've got somebody with knee replacement or hip replacement. Because of pain, they are now on loads of morphines, load of opioids. What that is going to do to them is going to depress their breathing center. It's going to make them to breathe less. Or again, if for no reasons, I am breathing so very less now. Like breathing less means I am struggling to throw out CO2. If I'm struggling to throw out CO2, what is going to happen? Somebody, you start retaining CO2. When you retain CO2, what is going to happen to your hydrogen? There will be a lot of hydrogen that are being generated. There was another way I was explaining this thing yesterday. Yeah, if I have to explain this thing 30 times, I don't know. I will keep teaching different things. I love biochemistry generally, but then hope I'm making sense. I'm not complicating these things. I just hope so. Now, again, if somebody is retaining CO2 for any of the reasons that I've listed, their body will start making a lot of now the other way around, if you've got a patient, let's say they have been admitted for chest infections, for instance. Let's say they've got a really, really bad chest infections, they've got sepsis, or they've got or let's say for no reasons now, because of insulin deficiency they've got, their body are now running less anaerobic respirations, or they are going into diabetic ketoacidosis or anything. What that means is having lots of hydrogen ions. They will start having lot of hydrogen ions. If they're having a lot of hydrogen ions, what is going to happen to their pH? Their pH will start dropping down. Again, another thing to remember in this equation that is, this is a dynamic equation here. This is a dynamic equation. If you got a lot of hydrogen ions here, the pH will be shifting. You don't want that. The equation will go backward. You will start breathing fast to remove the hydrogen ion. Another way to explain this. I'm just trying to teach in different ways so that we can understand this. Another way to remember this thing is simple term. Simple. CO2 is carried in our body in form of hydrogen ion. This statement might not be 100% true, but just for the sake of teaching, just believe this, that CO2 is carried in form of hydrogen ion. Meaning, if I have CO2, plenty CO2, what is going to happen to the hydrogen ion? It's going to be high in my body. If that makes sense. If I've got high hydrogen ion in my body, let's say due to any reason, you've got a patient, they've got chest infections, or they've got inflammation of the pancreas, or inflammation of this of the appendix, or whatever reasons, their body are now running anaerobic respiration now because of that bacteria that is trying to kill them. The body is running anaerobic respiration. Their body is now making lactate. So there will be a lot of hydrogen ions in their body. That hydrogen ion will start shifting their pH. We start making it to be going low. That is dangerous for them. They're going to die. So that is very dangerous. So what is going to happen? That is hydrogen ion. Your body will switch back to the counterpart of hydrogen, which is CO2. Without blowing out CO2. Oh my God. Am I making sense, please? Guys, is it making sense? Is it complicated? Or what do you think? Hello?
You're making sense, sir.
Okay. Can I get 2 more response just to show that, I don't know. Hello?
You're making sense.
It's okay, sir.
You're making sense.
Thank you very much. Thank you very much. Thank you very much. All right. So remember that. So this hydrogen ion again, let me say a few more things about this hydrogen ion before we leave this slide here. These hydrogen ions can be utilized in different forms in our body. I could have loved to go back to the previous equation, but because of that, plenty things within there, it could be very scary. But let's just look at this slide and keep it very basic. This hydrogen ion can be utilized in different forms in our body. Let's say somebody have got plenty hydrogen ions in their body now. Many reasons. The reasons could be on this side. The reason could be your body making a lot of hydrogen ion. The reason could be your body retaining CO2. If that makes sense, because if somebody is retaining CO2 will start breaking down and start making hydrogen ion. CO2 will start combining with water and making a lot of hydrogen ion. And again, hydrogen ion can be generated even without thinking about CO2 now, can be generated elsewhere in the body. If that makes sense. Now, these hydrogen ions now, because hydrogen ions, these are, in fact, let me say this. These hydrogen ions they are very nasty ions. They are protons that are very, very nasty. Why are they nasty? If they are not well controlled, hydrogen ion can damage your DNA. Hydrogen ion can damage your cell membranes. Hydrogen ions can make enzymes in your body not to be working well. Hydrogen ions can make the electrical activities of the heart not to be working well. The conductions of the brain, hydrogen ion can disturb the electrical activities. So they are very, very nasty. That's why I'm repeating this thing all over again. Hydrogen ion are very, very nasty. So we need to checkmate them. But again, aside from the fact that we've got monkeys to be checking them, what is the monkey here? You've got bicarb here, monkeys to be checking on them. There are a lot of other things we can do with our hydrogen ions. Hydrogen ion can bind with proteins like albumins, fibrinogens, all of those things. Hydrogen ion can enter into the cell just to drive them away from the blood. Hydrogen ion can enter into the cell. Again, hydrogen ion can combine with red blood cell. I have shown you that in the previous slide. They can combine with red blood cell. Hydrogen ion by blood. Blood can also carry them to the brain. Once they get to the brain, they can stimulate the respiratory system and they will start making somebody start breathing fast. And when you breathe fast, what is going to happen? You can also eliminate the hydrogen ion in form of CO2. Let me repeat these things. We want to control hydrogen ions. They are very dangerous. They can enter the cell. They combine with proteins. They combine with hemoglobins. They combine with what else again? You can pop them out in form of CO2 in your lungs. If that makes sense to somebody. And again, if hydrogen ion is too high, your pH will start dropping. And if your pH drops below 7.35, we said the person is acidemia. We love the term acidemia, academia. That mia, because we are dealing with blood here. It's not in secondary school where you just write A2SO4. No, we are dealing with human being here. Mia, physiological terms. All right. And again, if the pH is more than 7.5, that means you have lost a lot of hydrogen ions in your body. So what does that mean? It means you are alemia, if that makes sense to somebody. And again, before I leave this slide, one more thing I've got you guys to remember in this slide is this CO2 here is being controlled by your respiratory system, your lungs. We don't need professor to interpret that for us. You breathe out CO2. It's as simple as that. Bicarb here. Two things remember about bicarb. Generally speaking, bicarb is produced from CO2, generally speaking. CO2 that is coming from your cell. Remember that equation that is coming from your cell. And generally, this bicarb too can also go back when it can also blood carb, because I mentioned to you previously in the previous slide that this bicarb can also return back. When they return back to the plasma, they also float. Blood carries everything. When they get to the alveoli, they go back inside again. Forget about that. But just remember that this bicarb again, we can still puff them out again in form of CO2. Because you can see, if you look at SCO3, there is carbon there. Carbon is there. So you can pop those carbon there, you can still puff them out in form of CO2, if that makes sense. But again, another thing about bicarb that you need to remember is if you've got plenty of them in the blood, plenty monkeys, they are just chopping up, they are just grabbing and destroying the hydrogen ions in the blood. What is going to happen? The hydrogen ions are now scanty in the blood. The blood will start going into basic. This does not make sense. So again, we need to also keep checking them too. Bicarb too, they also need to be under regular control. So who is controlling bicarb generally? People will say kidney controls. But one thing about kidney is before kidney start kicking in, it might take some days, 2 days, 3 days, and like that before kidney start. So remember one thing now, without speaking too much of things here: CO2 controlled by respiratory system, bicarb controlled by metabolic system, which is your kidney, if that makes sense here. Now, give example, basic things now that you find on the world. Give example, where somebody can have too much of CO2 in their blood. I have said a lot of, they are not breathing too fast, they are breathing slow, they are very obese, they are morbidly obese, they got maybe muscle weakness, ascending muscle paralysis, like all these Guillain-Barré syndrome, motor neuron disease, or you've got somebody that they give them too much of pain medication, morphines, all those things, they depress their respiratory center, they make them start breathing less, in ICU. Give me an example of where somebody can naturally produce stuff that contain hydrogen ions, even without thinking about the other side of the equation. Yeah, somebody that have a really, really bad chest infections, somebody that bacteria is really, really trying to kill them, their body will start running anaerobic respiration. So those kind of people, they will normally have high hydrogen ions in their blood, if that makes sense. Let's crack on. Oxygen. So in oxygen here, of course, we have had a bunch of lectures on oxygen, but the oxygen here, partial pressure of oxygen, PO2 here, is just the oxygen in the plasma. It's not the one on your red blood cell. The oxygen on red blood cell is just the one you pop, what do you call it? Probe, what is that thing? Pop the oximeter on the patient finger, on their toes, on their ears that you check. But the ones you check with your ABGs is just oxygen on the plasma. And again, why are we checking oxygen on the plasma for a patient? Number one, because when somebody is acutely unwell, they are dying gradually. The SpO2, the what do you call it? The probe, the pulse oximeter you are popping on their finger might give you some false reading. That is the point I'm trying to make. For example, now if somebody have got carbon monoxide poisoning, you are likely to have false readings. You may have false readings with that SpO2, with that pulse oximeter. And again, PO2 can also tell you that at some point, if the PO2 is lower than some certain level, just SpO2 will start dropping very, very rapidly. What does this PO2 does? Let me keep this thing simple. What does this PO2 does? What they do is, just remember them like a pressure system. They are in the plasma. So what they do is, they are the one that push oxygen on the hemoglobin. They also push oxygen to the cell, if that makes sense to you. So what that means is, if I'm checking patient PO2 now, I'm also checking the way their cells is using oxygen, if that makes sense to somebody. So generally speaking, you and I now, we are more very comfortable. We are breathing, normal breathing, comfort breathing. So generally now, in our blood, in my plasma, in your plasma, we normally expect, ideally, the PO2 of oxygen there. If you run my ABG, or if they run your ABG, the normal value for oxygen should be between 10 to 14, and it might be greater than that. We don't want it to be less than 10. In somebody breathing normally with no chest concern, with no issues, with no what's it called now, hypoventilation syndrome or anything, normal person, no chest concern, no chest deformity, in those people, you will normally see PO2 greater than 10, if that makes sense to you. I have explained before the difference between SpO2 and PO2, and I've slightly talked about them now as well. I won't spend time on that again. So, and again, remember this, before we go into ABG proper, these are just basics. O2 does not have any significant thing to do with pH. It's not directly related with pH. Remember, what are those things that are affecting pH from the previous explanation? You need CO2. Hydrogen can affect pH, because once you have CO2 goes up, hydrogen will go up. Hydrogen can impact pH. But oxygen does not directly related with pH. But it is indirectly related. If I have the time, I can come back and explain that. But let's go with this basis first of all. So, all right, what do we have to remember here? PaO2 for normal person breathing on room air, they are not on oxygen. They are self-ventilating on room air. Their PaO2 should be between 10 and 14. Which means, now, one thing before I leave this place, let's say we've now got a patient now, they are using oxygen to ventilate, to breathe. And let's say they are on 35% of oxygen. Do you guys still think you and I, we are using 21% to have PO2 of 10 and 14 in our blood? Somebody is now using 35%. Let's say the PO2 of that person is now, let's say 12. Do we think that would be normal for that particular person? Can I just get one response? Do we think that would be normal? At the moment now, I am on room here. I am not on oxygen. Let's say you run my ABG now, and my PO2 is, let's say 12. And somebody is on the ward now, they are sick, they are being admitted. Now, they are on 35% oxygen, FiO2, and their PO2 is 12 as well. Do you think that PO2 is sufficient for that patient? Can I get one response? Guys, what do we think? Hello?
Could you please say that again?
Okay, thank you. What I'm saying is, right now, I am non-room here, I'm not on oxygen. And let's say when you do my arterial blood, and you find out that my PO2 is 12. Don't forget the normal is 10 to 14. And mine now, I'm not on oxygen, mine is 12. And you now have a patient on the ward, they are on 35%. They are using 35% to breathe. Naturally, me that I'm breathing on room here, I am using 21% to breathe. I am not on oxygen. But now you now have somebody on bed now. They are using 35% oxygen to breathe. And their own PO2 is also 12. What do we think? Do you think that PO2 is okay for that person at that moment? Response? Because these are things we need to understand. I don't want us to cram anything, because if you cram it, by the time you see patient, you won't be able to integrate that knowledge to your patient. The goal is for you to be able to see patient, know what you are doing, know what you are checking, know what you are doing for your patient, and make impact, significant impact. Of course, ABG is not something you normally see people just doing randomly for a patient on the ward. For them to be thinking about ABG, that means, yeah, we are much more concerned about that particular patient. So we need to have a good understanding of what ABG is. Please response, guys. What do we think? Do we think that patient is okay at that particular moment? I am on room here. I am breathing with my nose and mouth. I am not on oxygen. I'm taking 21% from the atmosphere. And when you do my ABG, my blood is 12. My oxygen is 12. And somebody is using oxygen on the ward now. They are using 35% to breathe, to ventilate on the ward. And when you do their ABG, their PO2 is also 12. So is that normal for that person at that time? What do we think? Please, guys, I need
No.
response.
Yes,
Yeah?
it's normal.
It's normal.
It's okay.
Okay.
It has
Because
no
they are within
impact.
range, right?
Hello?
Yeah, I can hear you, ma.
It's okay. It's normal.
Okay.
It is just telling he has respiratory problem.
Okay, ma. Thank you very much. Can I get one more person so I can also relax for a while? Can I get one more
Okay,
person?
I think that for someone who's breathing 35% oxygen, the person should have higher PaO2, whatever it's called. It should be higher than 12 because they are taking in higher percentage of oxygen than someone breathing in room air. That's what I think.
Okay. Yeah. Why are you thinking that way? Sorry, not to challenge you. So what do you think? Why do you think that should be the situation?
Because they are taking in higher oxygen than the person breathing on room air, 35%. So the plasma should have more than just 12. Should be higher than 12. I don't know.
Yeah.
I don't know what I think.
Yeah. Thank you very much. Thank you very much. Nice contributions. Thank you very much, you guys, for that contribution. I think let's keep this thing basic. Just imagine now, if I now go ahead to remove that oxygen from that person, just thinking that way. Just imagine, of course, I won't do that in the normal sense. Just imagine I just go to their bedside and I just remove that 35% from their mouth, from their nose, or from their mouth, or whatever thing they are using to breathe that. Do you think that they will still be, their blood will still be 12 again? Do you think that will not drop down to 10 to 7 to 8 or something? So that shows at that particular time that PO2 for that patient is not normal for them at that particular time. That's what it means. Now, imagine let's say now you've got, let's bring another one. Let's say you now have somebody using 80%. And when you check their blood, their PO2 or PaO2 or whatever you want to call it now is now 12 as well. You now think that is normal for them? That would be normal. If normally everybody should be using 21. Somebody is now using 80. Big value, big oxygen, very, very, very big. Somebody is now needing to use 80 to be breathing 12. That does not make sense. That is true. That shows these are stuff we need to be conscious of when we are checking ABGs. Some people just look at baby and the oxygen is normal because it's between 10 to 14. What are you saying? Somebody is using 100%, highest oxygen you can give somebody in the hospital to breathe 12, and they are saying it's normal. That's not normal for them. So that shows if we are not getting that clinical reasoning right, we might be making wrong decision for that patient, and they might likely die. That's what it means. Because from 35, before you know, the oxygen can go up again. The oxygen requirement can go up to 45, 60, 80. At the end of the day, 100. After 100, where do you go again? You can't go anywhere after 100 again. And what else? So the end has come. That's it. But how do we just remember whatever thing? Always remember this thing in this way. Oh, we normally use 21. Somebody is now needing to be using 35, 40. If I now go to their best and I remove that oxygen from them, do you now think they will now still be breathing at 12? They will now still be breathing at 14? They will now still be breathing at 10? Just always think that thing in that way. And aside from that, some people also have another way to calculate that. Some people will just do PF ratio. I won't discuss that. It's a bit complex here. I won't discuss that. The other one I will just teach is some people will just know the normal list that you want to have, you want everybody to have is just 10. Just subtract 35 from 10. What is that? So if you subtract the value, that means for somebody that is using 35 to be breathing, I expect their oxygen in their blood to be as high as 25. Now they are on 12. If that makes sense to somebody, I give another scenario because I want somebody to get these things now. Please, 3 reactions. Let's say you've got a patient on the ward, they are breathing on Venturi mask. We all know what Venturi mask now is. We have taught oxygen. They are on Venturi mask, 60% oxygen, and the arterial blood says 14, 60%. Arterial blood, PaO2, when you do blood, it says 14. Is that normal for that particular person? 3 reactions, please. Guys, please. What do we think? Somebody is on Venturi 60% and the arterial blood says 14. Is that normal for that person at that particular time? Reaction, guys.
It's not normal.
Okay. Why do you say so, Ma?
Yeah, it's not normal because they are not breathing on their own. They are being assisted. So when that assistant is taken off, it will definitely drop.
Yeah.
So it's not normal for them. But if like for a normal person and that is not using any Venturi or any mask and they have that 14, then you can consider it normal.
Perfect. Perfect. Thank you very much. And what value are we actually thinking they should be having with that 60% ideally? What value are we thinking? Yeah, this person should be around this range.
Okay. Like that 14, you can subtract it from the 60%. You can subtract it from 60, then you get the exact value that they are supposed to reach, even with the use of the mask.
Thank you very much. Guys, we can also pop our questions, answers in the chat box. I'm also checking that as well. So now, so it's as simple as that. So that is not normal. But for a random person, just looking at ABG, yeah, 60% Venturi, they are on 14. That's normal. That's normal. They are not normal. They're not normal. You need to think, what can I do for them as a physios? Do they need my chest intervention? Do I need to mobilize them? Do I need to start winning the oxygen? Do I need to escalate? Just think about your physio stuff now. It's as simple as that. So just for the sake of simplicity, just think about whatever they are using to breathe, the FiO2 they are using to breathe, just subtract 10 from it. Once you subtract 10 from it, that would be like the normal estimate you are actually expecting from it. Another way to check that actually is just the PF ratio, but I'm not going to check that here. So let's crack on because of time. All right. CO2, we have said a lot of stuff about CO2. Again, if CO2 is too high, you're going to have a lot of hydrogen ions. Your pH will start going low. If you remember that fact. And if your CO2 is too low as well, if that is too low, what is going to happen? Your pH, you're going to have less hydrogen ions. Your pH will start going up. It's as simple as that. Normally in our blood, we like our CO2 to be between 4.5 to 6.0. Generally speaking, there might be some variation in all of these values, depending on where you work, depending on your laboratories or whatever. But for the sake, it's just the same concept. Once you understand these things, you can apply your value to whatever hospital you work and it's going to work well for you. It's as simple as that. Perfect. Bicarb, we have explained monkeys. If you remember monkeys, there are a lot of monkeys in our body. One of them is bicarb. Even hemoglobin is a monkey. Hemoglobin too, they also chop hydrogen because hydrogen can bind with them. Don't forget I explained hydrogen can bind with protein, it can bind with hemoglobin. So hemoglobin is also a monkey. They love to chop hydrogen. Because hydrogen are very nasty. If they are too much, problem. So monkeys, bicarb, normal value, we like them to be between 22 to 26. Some people will say 22 to 28, and whatever value is this. So stick with the one you are using in your setting. That's fine. So it's the largest, this monkey here is the largest Bovary system you have got in your body. And if they are too much or they are too less, your kidney will start kicking in and start doing stuff to regulate them. So always remember this thing. When we talk about metabolic stuff, think about bicarb, think about kidney, if that makes sense to you. Perfect. Then we crack on base excess. Base. From everything we have been saying so far, what looks like a base? It's just the bicarb. It's the monkey that looks like a base. CO2, I've been relating CO2 with hydrogen. So that's an acid, if that makes sense. Acid. So bicarb is your base here. So if you got a lot of bicarb, excess let's say now, don't forget the role of the monkey is just to chop, to get rid, to mop up the hydrogen ions. So let's say after your monkeys now, after they have cut all the monkeys in your blood, after the monkeys have cut all the hydrogen in your blood, you now have some monkeys now that are just sitting, laughing, gisting, crossing legs, smiling. What are they doing there? These are excess monkeys. So if you've got excess bicarb in your blood, what that means is you've got excess base in your blood. What could be the reasons? It could be maybe your kidneys have reabsorbed a lot of monkeys from your blood that you want to pass out as urines, the blood has reabsorbed a lot of bicarb from the blood that you want to generally get rid as in form of urines. It could be because of that. It could be because you've got less hydrogen ions in your blood. It could be maybe that is why you've got a lot of monkeys. You've got a lot of monkeys, but there's no hydrogen for them to catch. It could be because of that. So now it's as simple as if you got large numbers of monkey, bicarb, +4, +5, +5, +6, +7. What that means is you've got excess base, excess bicarb, excess monkeys. And again, if you've got, let's say, -1, sometimes you might see like anything less than -2, -1, minus this, minus that. What that means is you have lost too much of monkeys, or you have used up the monkeys that you've got in your blood. It's as simple as that. If that makes sense to somebody. What can make somebody to have excess base? That is what I'm trying to talk. What can make you to have excess base? And what is that base? Monkey, bicarb. What can make you to have them in excess? If your kidney is reabsorbing, bringing lots of them back to your blood, it could be because of that. That's one. It could be because you've got less hydrogen ion that they want to start working with. It could be because of that reasons. And again, remember the normal value is just -2 to +2. Let's crack on because of time. Yeah. How do we interpret ABGs? How do we interpret this stuff? Yeah. Please do not cram these things. These are very basic and very simple concepts because we need to use them for our patient care. So the first thing I normally check, if you give me, what do you call this thing here? If you give me ABG printouts, the first thing I first of all go check is their oxygen. Do that, guys. Why are you checking oxygen first of all? If something is going to kill your patient first, it's going to be oxygen. It's not going to be pH. It's not going to be CO2. If something is going to, don't forget, oxygen, like I mentioned in the previous slide, oxygen has no direct relation with pH. Oxygen is just alone. If something is going to kill that lady first or that old man first, it's going to be that oxygen. And if you are checking oxygen, we have explained something under oxygen. Don't just check oxygen and say, yeah, they are breathing on 12, their PO2 is 12, they are fine. No. What, even if it is not depending, I don't know, depending on where you work, even if what they are using to breathe that value is not on the list, ask question. Oh, is this person on what? Are they currently on oxygen device? What device is it? You should be able to relate stuff. Now, what device? Oh, they are on venturi max, they are on 35% venturi. Okay, now you can relate. If somebody is on 35, you can relate. Oh, this is what value I should be expecting. This is what they are having. Oh, they are on high flow, 70% or 80% high flow. Now you can relate. We have talked about that. Or they are on 2 liters of nasal spec, or nasal cannula, or nasal prong, whatever things you call it in your settings. If somebody is on 2 liters, how do you calculate that? I have mentioned to you 1 liter, if you remember, under oxygen, 1 liter will be around 24. Keep adding 4 to the rest. 2 liter will be around 28. If somebody is on 2 liter nasal spec, what is that? That's like 28. If they are on 28, you should know what you should be expecting on that ABG, if that makes sense to somebody. Then after oxygen, what else do you check? And if the oxygen is not fine, what do you want to do? Physios, we have taught oxygen. You can do stuff. Think about why are they having low oxygen? What can I do? Do I need to do my stuff? Do I need to do my physio stuff with them? I'm not going to talk about treatment here. Maybe we're going to have some trainings later on and talk about treatment. Now, acid-base status. What are you checking after oxygen? I'll go straight to pH. Why am I checking pH? Because I have explained your body likes certain pH, 7.35, 7.45. Anything higher, too higher than that, death. Too lower than that, death. The person will not. Too lower, like far away, far lower. The person will not be compatible with life. So you want to go straight again to check your pH, if that makes sense. And again, after your pH, what else do you check? I want to check what is driving that pH. What drives this particular pH? For example, you can go to best and somebody have, let's say, 7.30, 7.something, or 7.49. You go to their best and you see that is reading. What else do you want to check? The next thing I'm going to check is I'm going to check their CO2. Next thing I'm going to check is their CO2. Now, why am I checking CO2? These are in order of, what is it called now? In order of needs. That's why I'm doing my stuff. In order of needs. Why am I checking CO2 first? Because I know CO2 can make hydrogen, they can make bicarb, and CO2 again is a fast, your lungs regulate that. I am talking now, I am breathing now, I'm breathing out. So you want to check CO2 first before you go to bicarb, because you know monkey is regulated by kidney, and before kidney start coming into action, it might take 2 days, it might take 3 days. So I'm going to check CO2 first, then before I go check bicarb. If that makes sense, then again after I'm done with all of those things, if I'm happy with all of those things, I can then start thinking, is it compensated? Is it not compensated? Is it this? Yeah. But in order of needs, what is their oxygen? Are they fine with this oxygen? Am I happy? I'm not happy with this oxygen. If I'm at the bedside, I'm going to speak with the oh my God, I'm not very happy with this oxygen. Oh, what is happening? Yeah, I will speak with the doctor. I'm not happy with this. What can we do? I will look at the patient objectively and do my stuff with them immediately if I'm not happy with it. No, I look at their pH again. I look at just go in that order. If that makes sense, let's move forward because of time. Now, before I will go into readings again, I need to discuss type 1 respiratory failure and type 2 respiratory. Type 1 is just one gas being affected. Which gas? Oxygen. Standalone gas, oxygen, being affected. Like I mentioned, right now, you are breathing on room here, you are not on oxygen. The least, and you are okay, no chest concern, no ventilatory or no perfusion issues, and you normally expect your oxygen to be around the least, maybe 10. 10, you can be higher than that, no concern. The least should be 10. Now, if somebody is now below 10, all these things, actually, if I really want to treat this, I should be using oxygen saturation, but it's going to be too complex. And it's not, I mean, at the end of the day, it might be complex, you might struggle to get some stuff there, but let's keep it basic. Now, we want room here, normal person, 10. Anything less than 10, maybe anemia, not anemia, hypoxemia. Now, anything start dropping, stopping, anything below 8 now, we now begin to talk about, oh, type 1 respiratory failure. This person is likely to die of oxygen if we do not give them oxygen. Let's say they are on room here now, and you do their PO2, their ABG, and their reading says 8, 7. And ideally, we should be aiming higher than that. Oh my God. If you don't intervene, they are likely to die of oxygen. That's type 1. Type 1 is just PO2 less than 8. Then type 2 is just 2 gas, just like the name, type 2 gas. Now, oxygen will be involved, that's hypoxemia, and you're going to have to retain CO2 as well. If the CO2 is greater than 6.5, then it's going to be type 2. And again, let me say something here. There's one confusing thing here. Let's say somebody have high CO2, and the oxygen is normal. That is not type 2. That is just normal hypercapnic respiratory failure. It's not type 2. For you to have type 2, the 2 gases, that is why the name is coming from. The 2 gases must be present. Oxygen must be there, CO2 must be there, if I'm making sense. And again, what are the conditions that can make somebody to have low PO2? I think we need to discuss. Because oxygen kills faster. Remember that. We need to discuss. I think I've explained some of these things before as well, right? But I think in my previous slide, when I was teaching oxygen, I've shown you guys this slide. I'm not going to go into it. What are the reasons somebody can have low oxygen in their blood or in their plasma, whatever reasons? Number 1, think of people that normally breathe very low. They've got big chest, COPD. They've got GBS. They've got Guillain-Barré syndrome. They've got motor neurons. They've got what's it called now? Kyphoscoliosis. They've got all of those things. Chest deformity, anything. So in those people, their VQ, those people, their normal oxygen content in their body should be normally very low. Sometimes you might, if you work in critical care, for instance, now, you might find doctors setting, just like I mentioned to you when I was teaching oxygen, doctor can set target SAT, if that makes sense. So in this regard, the doctor can also set their PO2. They can say aim PO2 greater than, less than 8, usually less than 8 for people in this category. They might say aim whatever they say it is. So what you are looking at is, when you are checking the readings now, you are looking at what they are using to breathe that oxygen. You are also checking that reading now and correlating that reading with the target SAT, the target PO2 that the doctor has set, if that makes sense to somebody. Let me repeat myself. Like I mentioned in the previous teaching that some doctor can set target scale 1, scale 2. In the case of PO2, the doctor can also set, especially if you are working in critical care and you are working with some of these patient categories, they will just say PO2, MPO2 to be less than 8, APO2 to be this. We don't want PO2 to be greater than 10. Because in patients like this, like they are normally breathe very low. Normally, when they are able, when they are fine, when they are not sick, when they are doing their job, when they are doing their ADLs, they normally have low oxygen in their blood. Now they are being poorly. Now they've got chest infection, they've got pancreas, they've got surgeries. They are being poorly. They are sick. They've got these things in the hospital now. We don't also want to give them too much of oxygen, because if you give them too much of oxygen, I think I explained hypoxic drive last time, even though it's an old concept. Now, or the new concept is just VQ mismatch. So I won't teach that concept again. I think I have explained that in the last teaching. So if you give them too much of oxygen, what is going to happen to them is they will start retaining more CO2. That is why you will normally find doctors setting their PO to be aware of that as a physio. And that is your goal. So you don't want to mess yourself up by looking at the ABG and say, yeah, this person is not breathing well. And again, somebody is telling you, check their PO2. This is what the doctor are happy with. So you should be happy with that as a physio. You don't have to challenge that. You don't want to say, everybody should be greater than, because they are on 80 now, their PO2 should be greater than, I would be happy. I would be much more happy if their PO2 is greater than 14. You are not, your clinical reasoning should be challenged. That is not correct. Because you can also find some patients that I also said their PO2. That is the reason, that is what message I'm trying to pass across here, if that makes sense. Some other reasons why PO2 can be low: if you've got diffusion issues, let's say you've got the alveoli is thicker than expected, or if your alveoli is thicker than expected, like let's say you've got fibrotic lung, your lung is getting, it's getting fibrotic, or you've got pulmonary fibrosis, whatever reasons that will make the alveoli wall to be thicker than expected. Diffusion issues, oxygen can go low, or you've got, let's say, collapse. Your lungs have been collapsed, lung collapse, you've got fluid in the lungs. All those things will make ventilation difficult. Oxygen, I explained using oxygen, and I explained using husband and wife when I was teaching this thing last time. I told you guys that oxygen is like the wife, the blood is like the husband. They love each other. If you've got a lung collapse, there's no space for oxygen to go to be able to transfer to the blood. If you've got that issues, ventilation issues will happen. There will be VQ mismatching. In that regard too, people can start having low PO2. I don't want to spend too much of time here. I've explained some of these things last time. We are entering into the business of ABGs. Now, respiratory acidosis. Even without looking at the slide, respiratory, what does respiratory means? We are talking CO2. Anytime you hear respiratory, you know it is CO2. Acidic. What is acidic? In everything I've been saying, what is the acidic there? CO2 hydrogen, CO2 hydrogen. These are stuff that are having to do with acid, if that makes sense. Now, let me just tell you guys one basic stuff here. So anytime you are looking at the ABGs and you find pH and CO2 going in opposite direction, no way, it is respiratory. I can explain that, but I won't do that here because of time. Anytime you find CO2 and pH going in opposite direction, it's going to be respiratory. Just take it. But if you need me to explain, I can do that. But because of time, let's move forward. So now, if you look at this now, respiratory acidosis. What is that? What does that mean to you? Don't cram. Respiratory acidosis. Oh, this person have gone high hydrogen in their blood. What could be the reason why they're having high hydrogen? For them to be acidic. Oh, now they are breathing low. They've got COPD, they've got muscle weakness, they cannot breathe out very much. Or now we give them too much of pain medication, they are very drowsy on the ward. That is why, those are the conditions that can make somebody to start retaining CO2. Now, if they retain CO2, what is going to happen? Think about that equation. CO2 will start making a lot of hydrogen, and that is where the acidity is coming from. And what is going to happen to pH if they have high hydrogen? What is going to happen to pH? The pH will start going down, if that makes sense to somebody. Respiratory alkalosis. Where is that coming from? Don't forget, if pH and CO2 are going in opposite direction, it's respiratory, definitely. Now, and if the pH is pointing up, it's going to be alkalosis, definitely. Now, think about alkalosis. Respiratory, CO2. Okay, If somebody is retaining CO2, you are making a lot of hydrogen. However, if somebody is breathing very fast, what are you doing? You are throwing a lot of CO2 out. So if you are throwing a lot of CO2 out, what is going to happen to hydrogen? The hydrogen will drop. If the hydrogen drops, what happens to the pH? pH will go high. Give me some good example. Somebody that you can go to the bedside of a patient is very panicked. They are hyperventilating, they are breathing fast, or the anxiety. All these things will make you to throw out CO2. If that makes sense to somebody. Please, are we getting these things before I move forward, please? Guys, please. Is it making sense to us, or are we lost? Is it getting complicated? What do we think? Is it making sense?
It's making sense, sir.
Perfect. Thank you. Just look at the chat box. What people say. Okay.
Please, what is NMD?
Oh, thank you. Neuromuscular disease. Neuromuscular disease.
All right. Thank you so much.
Thank you very much. Yeah. Yes, sir. All right. Let's move to the next slide. Now, another slide. Metabolic. You know, we've been dealing with two things: CO2 and monkey. CO2 and monkey. CO2 is breathing. Your lungs is working. Monkey, kidney. That's bicarb. Remember the monkeys. Now, I would like to use this equation here because I don't want us to cram this. Honestly, if you cram, by the time you see patient, you will just be lost. Believe me. And wrong decisions, if you are the senior officer in charge, you are looking at that poorly man in bed that is dying, and that wrong decisions you are making for him, he's going to die. That's it. So we need to think about supporting our patients, supporting our people. These are not patients, in fact, supporting our people. That should be the term that should be using. Thinking about supporting our people. Now, come back to this equation here. Please look at that equation on your screen. Now, we know hydrogen is acid, right? Now, you know the other time when I was explaining this thing, I explained that there are two ways to make this acid. It's either you use CO2 or it's either your body start making hydrogen for no reasons. They start making hydrogen. Let me give an instance. Somebody that is sick, they've got sepsis, they've got global infections, trying to kill them, bacteria, plenty bacteria in their body will switch and start doing anaerobic. They will not be, in fact, the oxygen demand in their body will be too high. So their body will struggle to meet the oxygen requirement. So the body will switch naturally to start breaking glucose and start making energy. From there, hydrogen can start getting out. So if your body is making a lot of hydrogen, that you are tending towards acid. What kind of acid here? Metabolic acidosis. It's as simple as saying this left side of this equation here is respiratory. If I'm using CO2, respiratory. If I'm using anything bicarb, hydrogen stuff, it's more of metabolic, if that makes sense to you. Now, so if your body, if let's say you've got diabetes ketoacidosis, or you've got sepsis, you've got inflammation somewhere, bacteria trying to kill that man, kill that lady on that bed. So the body start making a lot of hydrogen here. That is tending towards metabolic acid. Another reasons, if you've got plenty hydrogen, ideally we should be having this bicarb here to mop them, the monkey. They should be available to, to chop up those hydrogen. Now let's imagine now, for no reason, your body does not produce enough bicarb, or you have used up all the bicarb you've got here. You're going to have high hydrogen, if that makes sense to you. So what that means is when you talk about respiratory acidosis, it's either the hydrogen is plenty, or it's either you have low bicarb. If I'm checking an ABG now, and I see, forget about respiratory part now, and I see bicarb dropping, the first thing that will come to my head is, forget about compensatory or something now. You might also be thinking, oh yeah, it is likely to be. And you see the pH going down. Again, just like I mentioned to you guys when I was teaching respiratory, if pH and CO2 are going in the same direction, we said it's respiratory, no doubt. If pH and bicarb and monkey are going in the same direction, it's going to be metabolic, if that makes sense to somebody. Now, to not decide if it is acidic or alkaline, I will just need to check my pH. If the pH is dropping, acid. If the pH is going at basic. Let me repeat this thing. I know it's complex, getting complex. Sorry about that. Let me repeat. Now, what are the conditions that can make somebody to be in metabolic acidosis state? If you have less bicarbonate, just think about that. It's as simple as that. If you have less bicarbonate, what does that mean? You're going to have plenty hydrogen because monkey are there to chop the hydrogen. So if the monkey are not there, what is going to happen to hydrogen? Hydrogen will be plenty. Another example, aside from sepsis, bacteria trying to kill somebody. Imagine somebody losing water. In fact, I used to tell my junior colleague, remember this thing like, because if you are working on surgical wards, following surgeries, patient can be vomiting, they can because of anesthetic agent. If you see patient, if you are throwing up means somebody is vomiting. That's how I always tell them to remember it. Throwing up, vomiting, throwing down. Throwing down means what? They are losing water. If somebody is losing water, they are like diarrhea, all those kind of things, they are losing stool and all those kind of things. So what are you losing? You are losing bicarb. If you say a patient, let's say in the history of the patient, you say, or you are reading the patient, the patient is diarrhea, they are poorly dead. You even before looking at their ABG, should be have some clinical reason. Yeah, they are likely to be maybe something like that because they are losing bicarb. If that makes sense. If somebody is throwing up, what is throwing up? You are vomiting. When you vomit, what content are you losing? You are losing the content in your stomach. What have you got in your stomach? You've got acid in your stomach. So you are losing acid. So if you lose acid, so what are you going to have left? You're going to have monkey with no acid. If that makes sense. If you have monkey with no acid, then what is going to happen to pH? pH will go up. Let me say this thing again. If you are throwing down, you are losing bicarb. If you lose bicarb, hydrogen is going to be there. Acid, metabolic acidosis. If you are throwing up, you are vomiting. What are you vomiting? You are vomiting hydrogen. What are you going to have left? You're going to have monkey. And what is monkey? Base. Then pH will go up. Allosis. If that makes sense to somebody. We'll crack on again. Compensations. I'm not going to waste time here as well. I'm going to just use this equation. Look at that equation. There are two compensations here. That's acute compensation and there is subacute. Acute is just your respiratory system. It's very fast. If there is anything going on in our body, the respiratory system will kick in immediately and start regulating the CO2. Don't forget about that. Now, I'm going to use, let's say you've got people that normally breathe less, or by any chance, somebody is normally very active, they do their stuff, ADL, no chest concern. Now they are being admitted in the hospital now. For no reasons, doctors start giving them lot of opioids, lot of pain medication because of their complaining of pain and stuff. They start giving, you see this thing on the ward a lot. You just walk down to them as a physio. This my patient is not engaged, and I'm thinking, will it be, when you look at the drug chart, these are stuff we want physios to be doing. Oh, these are morphines. How often are they having those morphines? I'll just walk to them, please. This is my patient, these are my concerns. Do you guys consider reversing that? You just give them some medication to reverse the overdosage of morphine they are being on. These are stuff we want to be able to be doing on the ward. Anyways, let's come back. Let's say you've got that kind of patient on the ward now. They have been overdosed with morphines, or acute COPD patient, for instance. So what is going to happen is their CO2 is going high because they cannot breathe out very much. They are retaining CO2. CO2 will create where is my cursor? CO2 will create hydrogen ion and it's going to create this monkey. At that particular moment, you are retaining more CO2. So your body will start making lot of monkeys, lot of hydrogen, lot of monkeys, lot of hydrogen. And what are the monkeys doing there? The monkeys are trying to catch up. They are trying to get rid of that hydrogen ion because the hydrogen ion can destroy cells and destroy many things in your body. Now, if you are looking at that compensations, if you are looking at, let's say, ABG for somebody, that particular person, what you're going to see on the ABG is the CO2 will go up. Their pH will drop down. And when you check their bicarb, that bicarb might still be at the normal range, but you might find it at the extreme range. Don't forget the normal value for bicarb is less 22 to 26. You might find bicarb sitting at 26. That's acute compensation. Bicarb trying to regulate that monkey. Kidney is not coming into play in acute compensation. It's just your breathing, normal breathing now that is working. If that makes sense to somebody. If that makes sense to somebody. Let's say again, let me repeat again. let's say you've got somebody that's normally very fine, now they are being overdosed on morphines now. What is going to happen now? They are retaining CO2. CO2 will start making monkeys and hydrogen. And why is the monkey being made? Monkey is just to remove the hydrogen ion. So that means there will be a slight rise in the monkey in the body, but it will still be within range. But when you take the ABG, their CO2 will go up, their pH will start dropping. But monkey might go up, but it will still be within range, if that makes sense to you. Another acute compensation, let me tell you, respiratory, breathing now, breathing. Let's say you have somebody now, sepsis, now they have plenty bacteria in their body, hydrogen ion is now plenty in their body. Now, the normal monkey that you have in your body, 22 to 26, they will start coming out to try to remove those hydrogen ion, remove them. At some point, what is going to happen? At some point, you might get, even before you exhaust all the monkey there, another thing will happen. Hydrogen ion is dangerous. We need to get rid of them. Some hydrogen ion will go into the cell, some will bind with protein, some will bind with hemoglobin, some will start pushing them to different areas in the body. Another thing that will happen is some of that hydrogen ion will also go through the blood to the brain. And once you get to the brain, they're going to stimulate your Appling center, your breathing center in the brain, and you start breathing fast. And when you start breathing fast, what that means is you want to remove CO2. And that CO2 that you are removing, in what context? You are removing hydrogen in form of that CO2. Oh my God, I don't know if that makes sense to somebody. The equation will just go back so that you can start blowing out CO2. And that hydrogen, I have explained it before, that CO2 and hydrogen are like, just see them like a surrogate. A surrogate. So once hydrogen ions are plenty, your brain will get stimulated and you start blowing off high amount of CO2 out in order to get rid of that hydrogen ion. If that makes sense to somebody. If that makes sense to somebody. And again, that means if I go to the bedside of a patient, one more thing I want to mention here, so that we guys can know the importance of ABG. If I go to the bedside of a patient, they are acutely unwell now, and I find out that they are hyperventilating at the moment. A normal person, let's say physios or let me say not just physio, let's say medical staff, clinicians now, with that their foundations ABG are not very strong like that. When they go to, they might even say, oh, the problem with this patient is respiratory. It's respiratory problem. It might not necessarily be respiratory. You go to the bedside of a patient and you find them hyperventilating. It might be something else. That's what the point I'm trying to make. It might be, don't forget, what I just explained now, somebody was hyperventilating because of what? It's basically because of the hydrogen ions. It's because of the infection they have. It's not even anything respiratory this time around. So it is ABGs that it is your ABG that is going to tell you that, oh, this problem is not respiratory, then the problem is metabolic. The fact that they are hyperventilating does not mean the problem must be respiratory. That's what I'm trying to pass. If that makes sense to you. The fact, let me repeat that, the fact that somebody is hyperventilating does not mean the problem must always be from the lungs. It could be somewhere else in their body. If that makes sense, that is compensation. So in that regard, what your lungs was doing is just to compensate for the abnormality in the hydrogen ions. If that makes sense. Now, subacute compensations. Now, this is kidney coming into play. Maybe after 2 to 3 days, kidney will now start kicking in. Don't forget the role of monkey. You've got plenty hydrogen ion now, plenty. And these are dangerous. They can damage the DNA, they can damage the cell, they can destroy the cell membrane. We need to get rid of them. Oh, and now you have exhausted all the monkeys that you've got in the blood. What is going to happen? Kidney will now start thinking, oh, now I need to come into action. The blood, the urines that you want to start passing out, the kidney will start reabsorbing, start bringing back monkeys from that urine into the blood. That is renal compensation. It takes what's it called now? It takes days to be able to do that for kidney to kick in. But what am I trying to? Because these are real life. Everything we are discussing here, these are real life things. Something you're going to see on a day-to-day world. So again, remember these things. That again, the fact that somebody has got this problem, it might not really be that problem. It might be something else. A case of somebody hyperventilating, it might be something else. Remember that. So respiratory is going to, between seconds to minutes, respiratory compensations will happen. But for renal compensations, it might take days for that to happen. All right. I'm not going to come back to this slide again. I think I have covered that. Again, I'm not going to cover this. How do you analyze ABG? Check their oxygen, check their pH. What drives the pH? CO2. Check CO2 first. After CO2, check bicarb. After bicarb, is there any compensation? Check for that. We have talked about that. I'm not going to touch this slide also. It's just further explanations. I'm not going to discuss this as well. I love these things. I used to teach my colleague, but I'm not going to explain these things. Other stuff that you might find on the ABGs. I think it might not necessary for me to teach this as well. It might not necessary, but just know there are other stuff you can find. You can find anion gap, electrolytes, urea creatinine. I think people can relate what urea creatinine means now. It makes sense to us now. Electrolytes, I have explained sodium, potassium. I have mentioned what chlorine means today as well, how interaction with chlorine and bicarb. Might not necessary for me to go in details of all of these things, but let me just move forward to let's have clinical. Now, guys, I can't do this alone right now. I'm going to be needing us. I'm going to be needing our clinical reasonings. We've got some questions, some patients to see together. So we've got some patients to see together here. So the first patient here, this patient is, I think it's in University Teaching Hospital Ibadan. So the patient have come in with infective exacerbation of COPD. They are on the ward currently. So their ABG is, the pH is 7.31. Their PO2 is 15.59. Their PCO2 is 10.98. Their bicarb is 26. Their base excess is 2. And their FiO2 is 8. Can we just say there's no right? I don't even care if you are right, if you are wrong. All I just need is just participation. What do we think, guys? Just pick some values, relate what they've come into the hospital to. We know their background. They've got, infective exacerbations, infection on top of their COPD now. And they have been admitted to the ward. And we only have their, what's it called now? We have their, what do you call it now? Their ABGs. And these are the values. So what do we think? So I don't care, guys. And we have people to just run this, maybe 2 to 3 persons. Then we have my input as well. Yeah, guys, what do we think? Yeah, guys. Yeah, I need us to speak up. I also need guys to pop the answers in the chat box as well. Guys, speak up, raise your hand. Let's have think. I don't care, honestly. We don't care, yeah, if you are right or you are wrong. We are just here to build our clinical reasonings. There's nobody that is right. There's nobody that is wrong. So guys, raise hands. What do we think? Just analyze stuff. Analyze stuff. Yeah.
Okay,
Who is there?
Dr. Lagoke, I would like to make my contribution.
Yes, sir. Go ahead, sir. Thank you very much. Yes,
From the values that you posted on the slides, one can see that the carbon dioxide value is on the high side, and as a result, it will be there will be more hydrogen ion in the blood system, in the system of the patient. So with more hydrogen ion, the pH will be going down, and very soon it will be acidosis. The person will have acidemia. So that will give work to the bicarbonate to do the mopping up with time, so that the patient will be able to have less hydrogen ion in his body. So that's my contribution. Thank you.
Yeah, thank you very much, sir. Thank you very much. Thank you. Thank you. I really appreciate that. Perfect. Good stuff. Thank you. Yeah. Who is there again? Who is there? Please, guys, share your reasoning with us, please. Good evening, ma'am.
I'm here.
Yes, ma'am. Speak up.
Okay. From the data given, the PCO2 is high, so which means there is retention of CO2 which will lead to increase in the hydrogen ion. And this hydrogen ion, as it is increased, the pH is dropping, is going down. That says something more on the 7.31 that was gotten here. So the pH is down. And even though the pH is, even though the hydrogen ion is increased, the bicarbonate is within the normal range, even though it's taking it out. It's taking the hydrogen ion out, but it's still within normal. So the PO2 is also a bit high, because from the range it's 10 to 14, but this patient is having about 15.59, so it's a bit high. So in this case, I think this patient can be there's acidosis quite all right, there's acidemia quite all right, and this patient can be hyperventilating.
Okay.
I'm trying to, sorry.
Yeah, honestly, you've given some brilliant stuff, honestly. Yeah. Thank you very much. Good stuff. Interesting stuff. Yeah. One more person, one more, two more. Guys, pick up. Others, we can pop our stuff in the chat box. I'm reading them as well. What you think? Pop them in the chat box. Speak up. Because we're gonna be with the patient. We're gonna see patients like this in the hospitals. Or how do we? Yeah. Yes, ma. Go ahead. Hello, ma. We can hear you.
Hello, good evening, sir.
Yes, ma. Good evening, ma.
Okay, from what we have here, I can see that the pH is low, so we are looking at I'm going to suspecting acidosis. So my next move is going to be, where is this acidosis coming from? So
Hello. Oh, I think we lost her because of network. Yeah, one more person, because the most important thing is being able to interpret, adapt that to your patient, put it in the context of the patient.
I can go to is it's high, so we are coming from the respiratory. Can you hear me, sir?
Yeah, we can.
Okay. So my diagnosis is going to be respiratory acidosis.
Okay. Good stuff. Thank you very much. Interesting. Yeah. I'm very happy that we are able to identify that there is an acidemia going on with this patient, and that is actually shifting this patient pH. Yeah, which is great. Thank you. Interesting stuff. Yeah. Guys, one more. Let me check the chat box. One more. Yeah. One more person.
I will go fit contribute more time for you.
Hello, we can hear you, ma. All right, maybe I just share my opinion on this. Like I mentioned the other time, I like to go from the most, I like to do it in terms of priority. What do I check first? What is likely to kill this lady first? It's going to be oxygen. It's going to be oxygen. If we are not, we need to check first. Are we meeting the oxygen requirement of this lady? I think that's the first thing. Check the oxygen first. Guys, are we happy with the oxygen? This person is using 80% through high flow. I believe everyone knows what high flow is. We discussed last time. Now, this lady is currently using 80% to breathe 15.59 kilopascal. To breathe 15, like almost 16. Are we happy with that? 80%. When the normal is 10 to 14. Somebody is now needing to be using 80% to be breathing 15.57. That's why I mentioned the other time that if you just look at the ABG and say, yeah, what are they on? They are currently having PO2 of 15. That's fine. Normal is between 10 to 14. Yeah, they are fine. You might need to look closer. You might need to look, like, be objective with them. Because otherwise, if you are not meeting their requirements, they might die of hypoxemia or hypoxia. So we need to look very, very closely. Now, looking closely here, somebody is using 80% to be breathing around 16 kilopascal, 5.9 kilopascal, 15 to 5.9 kilopascal. What does that mean? To me, that's not adequate. Because ideally, I am expecting their PO2 to be as high as 70. Remember what I told you guys the other time. Just subtract 80 minus 10. That should be 70. Even though you might not likely see somebody with 70 PO2, but you expect that to be as high as something like that. 80 is huge. 80 is huge. Normally, we should be using 21. Somebody is now leading 80. So that means at this point, that PO2 is not optimal. That is what it means. It's not optimal for this lady at the moment. So you know, what does that mean? So if you just remember again, if you remove that 80%, remove that high flow from this lady, do you think this lady will be compatible? Do you think this PO2 will not start dropping down? 15 will drop down to 12, 10, 7. In fact, lower than 8. It's going to drop lower than 8 because 80 is huge. But ideally, we should be expecting now to be having something like as high as 60, 70. But now she's on 15. She's using 80 to be breathing 15, 16. That's too low for her. So that means that is hypoxemia, low oxygen. That is what that says. If that makes sense. Look at the PO2. Don't forget, the next thing I'm going to check, I've checked oxygen. What is the next thing you're going to check? Check the pH. Correlate the pH with the normal. Oh, that's low. That's low pH. So what drives the pH? That should be the next thing you want to check. Make it look real. Oh, what drives the pH? Oh, I think it's the CO2. Why? Because the CO2 is higher than normal. So how does the CO2 drive the pH? Because CO2 are now making plenty hydrogen in their blood. And plenty hydrogen is now shifting their pH to start going low. So if that continues, what is going to happen? Don't forget, I've told you, if pH is lower than expected, the person will not be compatible with life, will die. If that makes sense, just make this thing look real. Don't make it look like paper stuff. Oh, I'll just say, oh, 80, 80, 70. I'm not happy with the PO2. That's low, hypoxemia. Look at the pH. Oh, that's low. What drives the pH? PO2. Oh, PO2. Oh, because they have plenty hydrogen now. So that plenty hydrogen now is now shifting that pH to be low. Now, look at the bicarb, the monkeys. The monkeys are just 26. It's slightly on the high side, but it's still normal. What does that say to you? It means, oh, the monkeys are, why is the monkey slightly on the high side? Why is it on 26? The reason they are on 26, the reason they are not on 24, they are not 25, they are not 23, the reason they are on 26 is monkeys are doing what they can to mop up, to remove the hydrogen ions at the moment. If that makes sense, what does that say? It's looking like something like an acute compensation. Acute, from what I just explained, it's looking like, oh, monkeys are doing their best, but there is no, ideally, till now, major compensations has not happened. But it's looking like monkeys are doing their best to regulate the hydrogen ion. I don't know if that makes sense to somebody. So again, oh, this is somebody with COPD. Oh, normally, these people should be breathing less, ideally. Now, normally, these people should be having low oxygen in their blood. Even in the hospital, remember when I was teaching oxygen, COPD patient, you want to be careful with oxygen you are giving to them. Oh, now you are needing to be giving this person plenty oxygen. Oh my God, plenty oxygen for COPD patient. It could even be, that plenty oxygen could even be the one causing their problem here. Don't forget, when you give COPD patient plenty oxygen, I have explained hypoxia drive. I have explained VQ mismatch. Go back and watch that video on oxygen because you need, that's why I'm trying to make these teachings to be very systematic. I don't want to start coming from top to bottom. I'm trying to make it something we can flow with. Now, if you give them plenty oxygen, what is going to happen to them? is they're going to start retaining CO2. They will breathe less. When they start breathing less, they will start retaining CO2. And when they start retaining CO2, remember what happened? Hydrogen ions start going up. And when hydrogen ions start going up, what is going to happen to them? Their pH start dropping. Would that be, you are making things in your head. Imagine this is your patient. This is how you think. You are thinking this thing in your head. Oh, could that be the reason why this lady is drowsy? This lady, in real life context, this person is likely to be very, very drowsy at the moment. That's what I'm going to say to you. This person, in fact, when PO2 starts getting higher than, let's say 8 point something 9, the person is likely to be drowsy. And if care is not taken, if you don't take good care of this lady here, this lady is going to go into coma, and respiratory arrest will set in and they will die. These are things that happens. If I'm making sense, put it in the context of a patient. Oh, COPD patient. I have told you, whatever you are interpreting, put it in the context of the patient. COPD patient, oh, plenty oxygen for them now. Why are they having testing oxygen? You are making that hypothesis in your head. Could that be the reason? Check. Oh, plenty. And what do you want to do as a physio? Think about, oh, we need to start thinking about how to win their oxygen. And again, now they already have high CO2 already. What do you want to do? We need escalation, immediate escalation. If we don't escalate this patient treatment plan, this patient will die. There is no way. We need to escalate. How do we escalate the treatment of this patient? This patient is likely to be needing NIV, non-invasive ventilations. They need BiPAP. These are discussions sometimes they might even call you in the middle of the night and say, oh, this is our patient. If you go to the bedside and say, you see, can I have the readings? The ABGs you did half an hour ago, can I have the readings? You can't look at it. And so, oh, I'm not happy with this. And you discuss with the consultant, I'm not happy. This patient needs to go on NIV. Get them on NIV. People will respect you. People will respect you. Anybody can prompt anybody. You can prompt that consultant that has been working for 30 years. They can prompt you as a physio that you have been working for 20, 30 years. It doesn't matter. What matters is what are we doing? What is the goal for that patient? If that makes sense to us. So we need to get this patient on NIV. How? What will NIV do? I'm not going to change that here. It's just biphasic, NIV, by 2 things. You've got something that will support their breathing, pressure support. You've got something that pressure support will also help to blow out their CO2 and stuff. You got something that also support their oxygen. You can even give them oxygen with that NIV as well. Something that, don't worry, I'm going to talk about equipment. I will bring the picture. I will find them. I will bring them so that we can make sense. So don't worry about that for now. Just forget about that. But just remember for now, what do you want to? Oh, this patient is, the oxygen we are giving them is too much. Would that be the reason? You are making that hypothesis in your head. What do you immediate response you want to do? Speak with the consultant. This person needs to go on another treatment plan, NIV, BiPAP, if that makes sense to you. And again, another thing could be driving this CO2 something beyond oxygen now. Another thing, could it be now they've got plenty stuff in their blood, in their chest, plenty secretions. Secretions too will also affect, can also impact CO2, can also make patients to retain CO2. I will not discuss that here because I don't want to complicate, but just remember that. Do you want to see what you can do with them as a physio as well? And again, once, let's say for instance, now you escalate to the consultant, they get them on NIV now. Is that the end for physios? My dear, it's not the end. You do your respiratory assessment, check their chest. What do you want to do with them? You do your stuff with them because you know the BiPAP is not going to remove. It's not going to remove. The BiPAP will only support their breathing, maybe oxygenation as well. Let's say now they are standing khaki. They've got a lot of stuff in their chest. The physio, will be the one that will manage that chest for them. That will do your stuff with that chest. And because if you still leave that chest there, nobody is going to manage that chest for them. You're going to manage the chest for them. If you don't manage it, you will still come. You will just be going back and forth, even with the NIV. And again, people can also die on NIV as well. So again, what I'm saying is, how do you interpret these things? Check the oxygen first. If you are not happy with the oxygen, either you're happy or you're not happy, check the oxygen. After that, check the pH. What drives the pH? After the pH, then look at the CO2 and the BiCAP, if that makes sense to you. Now, another question before we go to the second one. Another question is, how do we know? Because this is real life issue, real life. Real life scenario now. How do we know if this patient is improving. Let's say now the patient is now on something that can support their breathing now, that can help them to blow out CO2, give them oxygen. How do we know if this patient is improving? Physios, how do we know? 2 persons, please speak up. How do we know if this man, if this lady is improving? How do we know? What, like, if you now ask them, let's say, because generally you want people to do maybe ABG, maybe after an hour, 30 minutes, 1 hour, just because they might be needing to be doing series of ABGs, not just one. I went to their bedside. I checked the ABG they've had maybe 30 minutes before I came in. Now we support them with NIV. We need to check if they are improving. And I just asked them, oh, can you run another ABG for me? Or the doctor would, depending on where you work, can you run that for me? Maybe after an hour again, or maybe 1 hour. Then I will come back to check their ABG. These are what we do. Then check. So if you are checking their ABG now, how will you know if this person is deteriorating or they are improving? Physios, how do we know? Persons, please. What changes will you be expecting on the ABGs, on the readings? So what changes are you looking at? When you, let's say now you've gone, now you are coming, you've done your stuff with them, now you've gone, now you've come back to see them again. So what will you be checking on the ABG that will tell you, oh yeah, this man is improving, they're happy, everyone is happy now, something is going down, something, what are you checking on their ABGs? Response. Hello.
Hello, good evening, sir.
Good evening, ma.
Okay, for this patient, how I would know that the patient is improving is first off is considering the PaO2. So considering that the FiO2 requirement is decreasing, so that means the patient is on less oxygen at the moment. And then another important thing is that the patient clinically less breathless at that time, being placed on NIV. Also, is the PCO2 falling? Is it getting to normal? And is also the is the pH also rising towards normal? So those are the things I'm looking out for. I'm looking at the PaO2. That's patient is requiring less FiO2. Is the PaCO2 falling? And is the pH rising towards normal?
Perfect.
And is the patient becoming less breathless at the moment?
Yeah.
Thank you.
Yeah, thank you very much. That's a brilliant one. Brilliant contributions. Perfect. Thank you very much. Can I get one more person? You are coming back to see them now. What are you checking to check if they are getting worse or they are getting better? What are you just looking at? Somebody has spoken nicely. Yeah, which is great. Great stuff. Yeah. One more, please, guys. One more. We need to be contributing. We need to speak up. Yeah. Who is there?
Sorry, sir. Please, I would like some questions. Before I can answer this question, if I get to the ward and I request for a recent ABGs, will I, like, is the patient, maybe based on your question, the patient must have been off oxygen, right?
Sorry, I'm not getting your question. Sorry. I think the network is fluctuating.
No, like what I mean is, when I get to the ward, request for the recent ABG, is it that the patient must have been out of oxygen support, or the patient must still be on oxygen for me to observe what you are asking?
Well, you can observe. Well, it's gonna be like huge magic, and it's gonna be great because the goal is seeing them good again, like without oxygen, breathing on their own, breathing on room air. Yeah, if you go and they are on room air, that's fine. You will still need their ABG. Of course, they will still do ABG again, check how they are breathing on their own and stuff. Yeah, it could be again if they are still on oxygen again, or they are on NIV or whatever things they are on. You can also observe them to see how they are doing. And again, you also need to check the ABG as well. So my question is now, when you are checking the ABG now, either they are on oxygen or they are not on oxygen, or they are on NIV or they are not on NIV, how do we know if they are improving?
Okay, sir. When I'm checking to note if they are improving or not, For instance, if the patient is still on oxygen, I should be able to see the PO2 to be. Hello?
Yeah, I'm listening. Yeah.
Hello, can you hear me, Jean?
Yeah, yes, ma.
You see the PO2 to be around 60, 70
Okay.
in the ABGs. Then the PCO, the pH should be close to around 7.35 within the range.
Okay.
So I'll be sure in that case they are not driving through, they are not inclining towards acidemia. At least they are slightly back to normal.
Yeah.
Then the PCO,
Okay.
the PCO should be within the normal range.
Yeah. Okay.
It's 4.5, 4.5 to 6.
Yeah. Thank you very much. Good stuff. Yeah,
hello. Flow as well. Even if the flow is still given, that will prompt me to see the PO2 to be within the range I just mentioned. Okay. If it's still at the same high flow, about 80%.
Okay. Thank you very much. Good stuff. Interesting stuff. Yeah. At least being able to identify that the patient is improving, because ABG is not just for, of course, you can use ABG to diagnose, you can use ABG to know a patient that is deteriorating. You should be able to also use that ABG to know if they are improving or they are getting worse. I think somebody is trying to speak. Hello, sir. Think. Yeah. So generally speaking, to check, because like I mentioned, with somebody with this PO2, this patient is likely to be drowsy. We need to support their breathing. We need to assist them to get rid of that CO2. Because one thing about CO2 is, if you are retaining CO2, what is going to happen to you is you start feeling drowsy. You can even see some people, their hand will start shaking, twitching, like they call it flapping tremor. You will start having people complain. Some people might start complaining headaches. Some people might start, in fact, some people might even go into coma, respiratory, and before you know, respiratory arrest, and that's the end. So we need to support their breathing. So now the point here is, how do I know? Let's I'm back after an hour. I've done my stuff with them. Now I'm back after an hour now to check with them. So what I'm going to see if they are improving is, oh, we need this CO2 to start dropping down. If that makes sense. The CO2 might not, dropping down does not mean, yeah, it has to be 4.5 to 6.0 straight now. No. It's going to be, it start dropping. You might now start saying, oh, maybe 10.85, 9 point something. It start dropping gradually. CO2 will start coming down. Oh, everybody will, yeah, we are. Start cropping. So, you know, even in your notes, you want to start documenting that, oh, CO2 dropping down, trending now. This is the value. Put up the value there. Now, another thing you will start saying is, you might even start saying that their PO2 again start going up. Because we mentioned, ideally, this person should be having PO2 of something like 70, 60, even though it's just like a rough estimate. It's just to tell you that, oh, their oxygen should be that high with somebody on 80. But that does not mean in reality, oh, they should have see PO2 of 70. No, you're not going to see that actually. But it's just like an estimate, just to tell you, like, they need to be as high as possible. That is what that means, if that makes sense to somebody. So what I'm going to see in the PO2 is, the PO2 might start getting up. It might even be 6.0 something, 6 point something, it start going up. It's just the trend. We are not interested in acute hospitals. We are not interested in the real value. Because sometimes it might take a while for you to arrive at a particular point for a patient. What matters is, what is the trend of that? Even if you are checking blood, look at the trend. Oh, ABG, what is their trend from last 2 weeks? What is their trend in the ABG, their previous reading up to now? So you are now comparing results now. You are looking at their PO2 start dropping down. You are checking their PO2 start rising up. So if PO2 start rising up, what you will see, what you will normally see nurses doing on the ward, I mean nurses, like good nurses that are supporting their patients, and even physios. Now, let's say now when I go to the bedside now, and now the nurses just printed the ABG and they gave it to you. What you should be doing is, once their PO2 start jumping up, which is good, sign of improvement. What are you going to do with the FiO2? You will still leave that FiO2 there? That is the question. Will you still let them be on that same FiO2? Their PO2 is jumping up now, it's becoming better. Will you still leave them on 80%? If you still leave them on 80%, you want to reverse that thing again. Remember, this is a patient with COPD. If you give them plenty oxygen, they will start retaining CO2 again. You are trying to blow out CO2 and you still keep them on high oxygen. That does not make sense. And again, even if they are not COPD patients, their oxygen is getting better, they are improving. What do you want to do with their oxygen? Start bringing the oxygen down, because your goal is get them back to room here. I'm bringing the oxygen now, maybe they are 80 now. Oh, can we try them on 70? And when you bring it down to 70, what do you want to do? You pop in your probe, your oxygen, your pulse oximeter, check their SpO2. The SpO2 is fine. Maybe after an hour again, let's say you reduce it to 70 now. After an hour again, or maybe after 30 minutes, you repeat, you might ask the nurse again to repeat another ABG to see how they are coping. If their oxygen is still, if the oxygen is still going up, or if the oxygen is still okay, to check for their PCO2 again. And again, if they are fine again, you keep bringing down the FiO2. You keep doing that, keep doing that. And again, another thing you want to see again is pH will now start rising up, start going towards normal, start rising up. It does not mean when I now go back, I will now spine the patient, room here. Oh no, that's like magic. Of course, if you see that, everybody should be jumping up. Great stuff. Good clinician, we should be jumping up. But it doesn't really, in reality, it might not really work like that. It might be a gradual process back to normal. 80% is huge oxygen. In fact, 80%, it is unlikely for you to see 80% oxygen for a patient on the ward. It should be in the ITU. It should be in another ceiling of care, if that makes sense to somebody. So if I go back to them after an hour, how I might see the CO2 dropping, the PO2 going high, the pH going down, because these are my concern initially. Then I will start, now, once the oxygen is now jumping up, I will start bringing the FiO2 down. And nurses will be doing series of ABGs, maybe 30 minutes after an hour, to see how they are coping. And again, let's say I win the oxygen to, let's say we've been able to win the oxygen from 70 to 60 now, and they are struggling again. Their CO2 start rising, they are struggling again, or they are not maintaining their SAT. What are you going to do? You return it back. That means they are still not ready for that FiO2 you are putting them on. Then you bring them back to the initial one, not the former one, not the former one. If that makes sense. Please, guys, one response. Are we getting these things? Is it making sense, or am I just, I don't know. Is it making sense? Please speak. Please.
Yeah.
Okay, perfect. Let's do the second one. Another lady here. This man is, this is a gentleman here now. You've got this man in one of our teaching hospitals in Nigeria. What are we going to do with this man? This man is asthmatic. He's currently short of breath. The pH is there, the PO2 is there, the PCO2 is given as well, the bicarb is given, and you've got the FiO2. So what are you going to, this SVR means self-ventilating on room here. So what are you going to do with this patient? What do you think is going on with them? What do we think is going on with them? Pop your answers in the chat box. Speak up, open your mic. We don't care if you are right, if you are wrong. Just share your clinical reasoning, what you think. Yeah, somebody said, how frequent is ABG done for proper monitoring? If I will, if I will answer these questions, honestly speaking, the answer is as much as you can. Clinical reasoning, just your patient context. How are they presenting? How are they presenting? What are we doing with them at the moment? It's just clinical reasoning now. How are they presenting? What is the concern now? Are we so very concerned with the oxygen? Are we so very concerned with the pH? Are we so concerned that the pH is now going dangerously low? In that regard, you might need to might be needing to be doing series of ABGs. 30 minutes, after an hour, to see how they are doing, how they are coping. And you correlate that with the patient presentation. There is no, 2, 1. No, there is nothing like that. It's just in the context. And again, everything we are doing, either our patient is conscious or they are unconscious, everything we are doing should be harm-free. If we do not need to do an ABG, if you are doing that, you are a bad clinician. For example, now, if there is no need for us to be doing a particular test, why do you want to do it? So there should be a good clinical reasoning for you to be requesting for a particular test. That's what I'm saying here. If that makes sense. So there is no 1, 2, 5, 10. No, as much as you can, depending on the patient. Let's say for example, now somebody is struggling, they are previously on oxygen, and we just do your physio stuff with them, we get them on appropriate device, and then we come back after 30 minutes, we wind down the oxygen, and after another maybe second day, or they are with the nursing staff on the ward, they are fine. There's no need to repeat all those things again. It's as simple as that. It's just the context of the patient. So people on the YouTube, please questions, pop your questions there. Even contributions, I don't know how you can make your comment as well. All right, guys, we got this gentleman in one of our hospitals in Nigeria. What are we going to do with him?
Hello.
Yeah, hello, sir.
Okay, let me attempt using my clinical reasoning for this particular gentleman.
Yeah.
Now, as the rule of thumbs that we have gotten on going through this class, or the series of classes that we have had.
Yeah.
So looking at the first thing is to look at the oxygen.
Perfect.
I will say, looking at the oxygen, I think the parameter or the metrics around the oxygen is okay.
Perfect.
Then the pH is a little bit on the high side.
Okay.
Because it's between 7.335 to 7.45. But we are having 7.47 here. So it's moving into the alkalosis.
Yeah.
But if we look at the bicarbonates, it's within range, and the breathing or the oxygen, the respiration is driven within the room atmosphere or room temperature, room air. So I will say, looking at the context of the patient, asthmatic patient, short of breath, what should be done to this patient is to actually calm the patient down.
Okay.
Because what is driving the increase in pH will be the context of the patient, that the shortness of breath. So that means if we want to psychologically encourage the patient to try to maintain normal breathing, probably that can bring down the pH to, because it's just 0.002 we are seeing here.
Yeah.
If we can ask the patient to try to breathe normally, then we can see how that will drive down the pH level. I think that's the contribution I can make. Thank you.
Perfect. Thank you very much, Dr. Joshua. Thank you very much. Great contributions. I'm also reading through the chat box. People are popping in answers. Pop your answers. And I think people on the YouTube, I don't know if they've got access here as well, or if you've got access on the YouTube, I think so. I don't know if we can also get their response on board, if that can be copied there or something. Please, let's get a response. Let's get everybody to be speaking. Good response. Thank you very much. Great contributions. Yeah. Let me get yeah, people are popping in response in the chat box. Great contributions. Well done, everyone. Yeah, can I get one more person to speak on this patient? Yeah, thank you, Dr. Joshua. He related the patient with the ABGs, which is perfect. I love that, honestly, because it's not just about reading parameters, it's about putting that in the context of your patient. Yeah, what do we think? Yeah, maybe we just combine the two. And again, for this patient, if they are getting worse or if they are improving, how do we know? How do we know? Yeah, let me get somebody, speak with the parameters, speak with this, like correlate that with the patient presentations, and if they are getting worse, if they are improving, how do we know? One more contribution because of time. Guys, what do we think? Yeah, one more. Yeah.
Hello, sir.
Yeah, hello, ma. Yes, ma. Go ahead. Thank you.
Can you hear me?
Yes, ma.
Yeah.
Yes,
If
ma.
the patient is improving, the PCO2 will be increasing
Okay.
and the
Okay.
pH will start dropping towards normal.
Okay. 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 Good stuff. Perfect. Thank you very much. Thank you very much. Thank you very much. Of course, I think now I'm very, very happy because we are beginning to understand this stuff, honestly, and that is the goal. That's why we are here. The first thing, look at the oxygen. Oh, they are using 21% to breathe oxygen. Am I happy with that? 21%. Oh, this patient should be on room here. It's just like you and I. We are not on oxygen. 21%. It's not on oxygen. It's using that to breathe the level. What do I normally expect? Normally, I should be between 10 to 14, 10 to 14, 10 to 14. Now, if you subtract rough estimate, subtract 21 from 10, what are you going to have? You're going to have 11. Yeah, 11. Yeah, I'm not too bad, I'm still happy with that. Not too bad. That's okay. Cool. What else are you looking at? You look at the pH. 7.47. I think that's a bit higher than expected, than normal. Wow, what comes to your head now? What drives that? Come on, what drives the pH? Look at the pH. Oh, CO2. What is the CO2 here? The CO2 is 4. What does that mean? CO2 is dropping down. Why is it dropping down? Because CO2 is dropping down and the pH is going high. Why? Correlate that with the patient, asthmatic patient, short of breath. What does that mean? They are currently hyperventilating at the moment. So someone that is hyperventilating, from our previous explanation, what are they doing? They are throwing out CO2. As simple as that. So you will normally expect that CO2 is now dropping in their blood. If COP is dropping in their blood, the hydrogen will start dropping. If that makes sense, if the hydrogen will start dropping, what will happen to the pH? pH will start shifting to the right. It will start going up. That's what is happening in this gentleman. If that makes sense to somebody. And again, so now this is an asthmatic patient. We need to be very, very careful. Asthmatic patient in this group, you need to be very careful. Do you know why? Why we need to be careful with them is of course, when they are presented, let's say for instance, gentleman is presented in the hospital. Let's say they are in ED now, for example. The medical team will be on the lookout. They will be there doing their stuff with them. They will likely asthma patient sort of breath. This patient is no asthma, bronchoconstrictions, all of those things. They are whistling and stuff. They will be on salbutamol. They will give them intraproton. Physios, we need to know those drugs. We need to know them. Sometimes you can go to the bedside and see somebody whistling. You just need to medicate. Oh, this person, I don't know, but this person is whistling. Oh, can you get them on salbutamol? Don't do that. Anybody can pick up. See, it's not, I don't know, God will help us, but at the same time, we need to know some certain medication, ipratropion and so. And if it's very poor, somebody whistling, you can find them on IV magnesium. They'll be on IV magnesiums just to ease their breathing. And now it's as simple as that. Oh, I forgot something in the first case. Sometimes you might also need to be talking about their respiratory failure. What kind of respiratory failure is first one? The oxygen is dropping, the CO2 is like, that's type 2 respiratory failure. Don't forget I mentioned that before, type 2 respiratory failure. Now for this man here, the oxygen is fine. It's just the CO2 now. The CO2 dropping here, right? The CO2 dropping and the pH is going higher. So that is the case of this gentleman here. Now, at the same time, guys, the question here is, how do we know if this person is improving or they are deteriorating? See, for asthma patient, we need to be careful. Because ideally, normal thing, if CO2 is going, because we need the CO2 to start coming to normal. Ideally, for every other patient population, we want CO2 to start coming to normal, which is fine. We want what's it called? We want the pH too to start dropping back to normal. But in the case of asthma patients, it could mean something else to them. That could mean something else. That is why I keep saying put everything in the context of patients. Because for asthma patient that is whistling, they are being hyperventilating. By the time CO2 start dropping towards normal, it could mean that that patient is now getting tired. Now their ventilation is now starting to be failing. It could mean that now, because their ventilation is now starting to be failing, what does that mean? They will start retaining CO2. That could be a sign that if you don't get them into the ITU, or if you don't give them treatment that is expected of them, they might die. I know, let me say this again. I know it's somehow falling, but let me say it again. For an asthma patient, if CO2 is dropping, normally for an asthma patient that is hyperventilating, you will know, normal thing, they are hyperventilating, they are breathing very fast. When you check their ABG, what you want to see is, oh, CO2 is now dropping down. Normal, that's normal, because they are blowing out CO2. CO2 should be reducing, pH should be going up, which is normal thing, if that makes sense. Now, by the time they are getting tired, it could mean two things. Listen, this is what, let me check this thing again. This thing could mean two things. If CO2 start dropping down, if CO2 start increasing, it could mean that they are dying gradually. That is number one. And again, if CO2 start improving again, like start getting increased, it also means they are getting better. If you understand what I mean. So now that means when you are at their bedside, in fact, nursing staff, they should be running series of ABGs in this kind of patient group. And again, because everybody, for an asthmatic patient, everybody is always very concerned about their CO2. Because if you go to their bedside and the CO2 start going towards normal, and this person is now, they are hyperventilating before, and now they are now very, very drowsy. Hey. Oh my God, if you don't get them into the ITU, if you don't do stuff with them, they die. So, but now if I go see them at the bedside and their CO2 is now getting improved, is getting increased, and now they are still okay, they are chatting with me, they are fine, even though they are still whistling, they are still receiving their salbutamol meds or whatever they are giving to them. Yeah, I'm fine, I'm not worried. So that is why I keep saying every blood you are interpreting must be put in the context of your patient. Only a bad clinician will go to the bedside for a patient, asthmatic patient, that are retaining that they were previously hyperventilating. Now all of a sudden they get tired, they get fatigued, they are now started retaining CO2, and they are very drowsy, and you are not escalating that. Oh my God, if you don't do that, now the CO2 that they started retaining, what is going to happen to the pH? What you're going to see is pH will now start dropping down. pH will start shifting beyond normal. Before you know, anything else can happen. So the point I'm trying to raise here is context of patient. Put everything in context of your patient, and be careful with an asthmatic patient. I deliberately pop this question here because it's kind of somehow look silly somehow, but please be careful. The point is, be careful with an asthma. In fact, generally speaking, somebody like me, I'm not very worried with their oxygen. I'm not very worried. Now, I'm not very worried. I'm very much more concerned with their CO2, because this CO2 here can go, if it's getting high, it could be a sign that they are getting tired. They might be needing escalation, next ceiling of care. And again, it also means that they are improving. So put that into the context of your patient, if that makes sense to somebody. Let's say one more or two more questions, then we can call it a day. I'm not sure I can run the ops today. One more questions.
Okay, sir, regarding what you just...
Yes, ma'am.
The asthmatic, yes, regarding the asthmatic patient, that if the PCO2 is increasing, it could be maybe the patient is getting it's two ways. Either it's getting normal or is getting worse. So now, if at all is getting normal or is getting worse, what can we do in such situation?
Oh yeah, thank you very much from physio point of view now, from physio perspective, generally speaking, you could also, generally for an asthma, we want to be careful. Let's say now they are in the hospital now, they are being treated for chest infections. Generally for an asthmatic patient, I want to be careful in selecting my treatment plan or treatment techniques with them, because I know anything I do with them can further aggravate their airway and improve, like I'm worsening the, what's it called now, the bronchospasm there. So my intention is to help them. Now I'm worsening their conditions. So with asthma patients generally, physios are always very, very careful. You have to grade your approach with them. Now, let's say they are an asthma patient, they've got chest infection, they are standing cracky. I need to think about what techniques I'm going to be using for them. How are they presenting at the moment? Because if you do aggressive stuff with them, you can worsen their conditions and they will start retaining CO2, and that might be the end of them. But generally speaking, for an asthma patient, when you go to their bedside, you will find them on NEPs, salbutamol, ipratropiums, they might be on IV magnesiums. How do you support their chest if you are seeing them from chest point of view? Generally, they get them into what do you call it? Breathless positions, get them. And again, if you, let's say now they are standing chesty, get them to do some, maybe I need to support their chest, for instance. Now I can get them to do some active stuff if they are able. If they're active, I can get them to do some active stuff with them. If I need to do anything positive pressure, for instance, now I might want to go with maybe passive, maybe PEP device, anything that can passively mobilize secretions from central airway to peripheral airway. That's all I needed to now start bombarding them. Think of, oh, let's pass catheter. Oh, let's bombard them with positive pressure. All those kind of things. I want to be very selective in treating them. But let's say now the asthma patient, they are just whistling, and they don't really have chest concern, like physio stuff. What do you treat generally as a physio when it comes to chest? You are treating secretion retention. You are treating what is it called now? Work of breathing. You are treating lung collapse. You are treating what else do you treat? If any of those things are not present, you don't have business with the patient. Let's say asthma patient now, they don't have secretions. Their lungs is fine. It's not collapsed. It's just they are just whistling and say, at the bedside. Do I have business with them? I don't really have business with them. But believe me, as a physios, if you are in acute settings and you are doing your regular day-to-day work, doctors, they will think about, call physio, please. But it is now in your own judgment that you now want to decide, is this patient appropriate for me? Or do I need to just tell them I'm not indicated? If they don't have chest concern, those 4 things that we treat at the physio, don't have business to treat them. Just leave them. Just tell them, let's say now they call you to come and see this patient, and you meet them at the bedside, and you are looking at their ABGs, and you are seeing that the CO2 is now going high, and they are feeling drowsy. The fact that you don't want to do something for them does not still mean you should not escalate. Speak with the consultant. I'm just looking at the ABG of this gentleman, and he's very drowsy now. He was not drowsy before. Now he started. I'm a bit worried. I'm a bit worried with that. Tell them. It could mean that maybe you guys might be needing to consider another ceiling of care. They might be needing to be intubated and be ventilated to support them. All right. So maybe later on I will talk about treatment plan. What are you checking? Because you will see a lot of referrals, and you as a physio, you will pick them up. I don't have to wait for doctors to say, yeah, go and do this. I know my job. I know my job description. I know who to call if I'm in a particular situation. I know what to say to a doctor, because we need those stuff. Anyways, don't worry, we're going to discuss those things later on. But I hope I slightly answered that questions. I don't want to start talking about those treatment plan here, but just believe me, for asthma patient, it could be very tricky for if it's, and again, it could be the fact that now, let's say you've got an asthma patient, they've been admitted in the hospital, they normally mobilize, they ambulate independently unaided without any hate. Now they're in the hospital now, they cannot even walk. You've got reason to see them. You might not needing to be seeing patient from chest point of view. It could be mobility. Sometimes again, you might even find a patient that is chesty. Let's say they have chest infection and secretion on top of their asthma. When I go to their bedside, sometimes I can just say, what can I do with this patient? I don't want to further aggravate their bronchospasm, whatever. I can think about functions, using functions to treat their chest. How do I use functions to treat that? See, the best form of treatment a physio can do for a patient is getting the patient up and be moving. It's not keep somebody in bed. do this thing, but I can use functions if they are able. I'll get them out of bed, get them to sit out. When you are sitting out, you are shifting ventilations in your lungs. You are putting them in a position that they can naturally cough and clear their airway by themselves. When you stand them, when they are mobilizing, their mini volume will increase, their tidal volume will increase. They're going to increase their lung volume. So for a patient that is mobilizing, oh my God, you are doing them a lot of good. So you are helping them to prevent deconditioning in bed. Don't worry, we're going to talk about treatment. Let me just keep it low. I don't want to start bringing up unnecessary things now. But hope I've slightly answered your questions, if not fully for now. All right. I think the other question here is still about asthma. I think we should be able to interpret that. It's very direct. It's just like the first one. There's no point doing that. But I want us to do this. Oh, somebody is raising hands. Please, can you open your mic and speak up, Sma?
Okay, sir. So in this case, is postural drainage applicable?
Postural drainage is not even what you want to start thinking about here. See, don't worry. I'm going to talk about some of those physios. I'm going to talk about some of those physio techniques I'm going to talk about that at the word treatment, this thing that we do for patients generally. See, postural drainage. There are a lot of stuff you can do for patients. No, postural drainage. See, postural drainage is not somebody hyperventilating, their work of breathing is high, and you want to put them in modify or tilt the bed down. They might struggle. You might make that thing worse. It's not something you want to even start thinking about. Yeah. Rather than doing that, if they are having shortness of breath or they are hyperventilating, how do you can maybe get them in better positions that can fix their upper body? For instance, if they can assume tripod position in bed, if they can, depending any position of comfy. In fact, that's what I'm going to say here. Any position that will get them in comfortable, you want to put them on. That people can use different breathing pattern, like sit them up in bed. These are stuff you want to, because that as opposed to somebody lying flat, lying supine in bed now, when you put them in semi-fowler, when you sit them up in bed, that will better put their respiratory system, that will further put their diaphragm in a good advantage to be able to descend, to be able to go up, they will be able to ventilate better than putting them in flat positions. Just think about those positions. Or can you just slightly tilt the head of the bed up? Can you put them in semi-fowler? Can you, all of those things. So generally, in terms of position now, for example, sitting positions, when it comes to chest treatment now, sitting position is better than somebody lying flat. Standing is far, far better than somebody sitting. If that makes sense to somebody, don't worry, I'm going to explain those concepts. These are stuff you are using to treat patients on the ward. I cannot go to see, even if it is not asthma patient, somebody that is chesty and they can mobilize, and I'm keeping them on bed. I'm not doing the best thing for them. And I'm asking them to be blowing in central spirometer or to be doing the breathing exercises in bed when I should be getting them out of bed. That does not make sense. You are unnecessarily delaying making their chest more, because what evidence supports is not that breathing exercises you are doing in bed. It's mobilizing patients out of bed. That is real evidence-based. It's not giving somebody, in fact, in central spirometer, the evidences around it are very weak. When somebody can mobilize, we are doing that for them in bed. So don't worry, we're going to talk about those treatments. Let's just keep it low for now. Don't worry. We're going to talk about those things. And so let's talk about this. Maybe this might be the last one for today. I still got some plenty questions. I'm going to send the slide to you guys. You can dissect the questions. Can dissect the questions on your own. If there is any concern, pop the question up in the group page. I'm also on the group page as well. I'm more than happy to answer them. So let's answer this last one for today, because I'm getting hypoglycemic. I'm sorry. All right. You've got a lady 2 days after cholecystectomy. Their PEA is 7.449. Let's say this lady is on general surgical wards now. They've got cholecystectomy surgery. Their PEA is 7.49. You've got the oxygen there, their PO2 is there, their ACO3 is there, FiO2 is there. So what do you think? What do you make sense of this lady? Yeah? Let's get people to speak. Speak up. What do we think? What do we think? This last question here. This last questions. This is the procedure they've had. This is their pH. And what do you think of them? Of course, I expect the normal value is up here, so you can use that to interpret this as well. Yeah, this is the last question for today, guys. So let's answer this. Who is there? Who is the peanuts? Hello?
Hello, sir.
Yeah, go ahead, ma.
So from the ABG result, judging from the history of the patient is asthmatic and
No. I mean, sorry, not the asthmatic one. The cholecystectomy one. I think the asthmatic is similar to that one. The cholecystectomy. Yeah.
Okay, please let me go through it again.
Okay, guys, please let's pick up so that we can end the meeting for today. We'll do the other one some other time.
Hello.
Yeah, hello, sir.
Let me also try and attempt this.
Yeah, thank you, sir.
Checking the PO2. PO2 is the PO2 is low.
Okay.
The PO2 is low. And the pH also is on the high side. The PCO2 is also PCO2 is low. The bicarbonate is on the lower side also. Even though the patient is the FiO2 is on 31%. So for this patient, I will think I will need to like escalate this patient so that patient might need oxygen therapy.
Okay.
Because from the 21% is not the ABG is not it's not okay, it's not looking fine at 21. So probably the patient might need oxygen.
Yeah, cool. Okay. Cool. Oh, thank you very much. Nice contributions. I love that that reality here with this patient, which is this patient might be needing to go on oxygen. Yeah, 100%. Yeah, perfect. Yeah. Maybe one more, if we can see one more person to share their clinical reasonings.
I'm sorry.
Yeah, go ahead, ma.
My own observation, I think the bicarb is within the normal range.
Okay.
Every other observation he had is the same with mine, but the bicarb is within the normal range, and there will be need for oxygen as well, yeah, because of the PO2 that is low.
Okay.
And the PCO2 is low, so That gives rise to the decrease in hydrogen ion production, which also leads to the pH being increased high. So thank you.
Okay, thank you very much. Thank you very much. I think there are some questions here people have asked before. I thank you very much for that response. Brilliant response, interesting one. People have asked that somebody asked that what's the difference between pediatrics ABG and that of adults? Well, of course, there's going to be for peds as well. There's going to be the clinical reasonings. I know peds school is slightly different when it comes to correlating your readings with their presentations in bed, because in adults we've got a lot of compensatory. Even when it comes to breathing, you've got bucket handle movement, you've got what are these things again? You've got adults can generally have good respiratory reserve compared to peds, 1 year old, 2, 5. They are still young babies. So but just the same clinical reasonings as well. And again, there's going to be acceptable range for peds, acceptable range as well that you can also use. Oh, this is going on. Why is this going on? Why is this going down? And generally, again, for peds, you might, rather than ABGs, you might find people doing venous blood gas, VBG, ABG. And as a physio, I think when it comes to VBG, and the reason for that could be, maybe for peds, you can easily bleed them when from the venous side rather than arterial side, and again, venous blood gas is easily to just do rather than ABG. So all those kind of things. It's just that I don't want to combine that with VBG again. It could be somehow difficult for us to comprehend. So, and again, aside from that, another thing that I also want us to know is if I'm doing arterial blood gas, of course, that does not mean we can still not do VBG for adults too. You can do it. You can find people doing that as well. If I'm doing ABG for adults and somebody is doing VBG for adults, clinical reasons, ABG, normally arterial gas, arterial blood, they are very rich in oxygen. Artery carries oxygen, not the pulmonary aspect. Now, just remember this general circulation now. They carry oxygen to the cell, if that makes sense. Forget about the pulmonary stuff now. They carry oxygen to the cell. Venous. So what the oxygen the artery is carried to the cell, what does your body do with the oxygen? Your body will combine that oxygen with the glucose and CO2 will come out from it. That means the blood that will be going into the venous side, they will be more richer in CO2 than oxygen. If that makes sense. This is just normal stuff now. So if you are running ABG now, you are likely to be checking blood that are very rich in oxygen because oxygen can keep very fast. That makes sense. If you are running venous blood gas now, you know that in venous blood gas, the accuracy of oxygen in venous blood gas is, it's like, it has a K leg. Because generally speaking, venous blood gases are venous blood generally are blood that are very deficient in oxygen. Because why? Because already your cells have used those oxygen. The CO2, remember the equation that I explained initially, the CO2 that are coming from product as a byproduct of your respirations when energy has been released to the cell is what you'll be finding in the CO2 in your venous gas. So venous blood gas will be much more richer in CO2 than oxygen, if that makes sense to somebody. So, but just and again, in adult, maybe venous blood gas can be much richer in lactate if you need to be checking lactate. So there are reasons for all of those things. But again, it's still the same clinical reasonings. Just do your stuff. If you understand ABG, you can still transfer those knowledge to VBG. And it's all about you, what's the normal, what's not the normal, and do your interpretation. If that makes sense. If you want me to go over it in briefly next, I can go over it. Yeah, very simple stuff. I think there is another question. Yeah, somebody said ABG is not frequently done in Nigeria Federal Hospital ICU. Well, yeah, it could be in federal government hospital ICU. Well, I know we are complex. We are very complex. If there is need for ABG to be done, we need to be doing the ABGs. We need to be looking at patients' metabolic activities. We need to be looking at their pH. We need to monitor how they are doing. And that is why we need us as a physios as well. Because physios, there's no way you are treating somebody in ITU in Nigeria, either they are peds or adults now in ITU, and you are treating them for chest, and you will not be requesting for ABGs. It's not possible. Because how will you know if their oxygen is getting better? If their CO2 is getting better? How will you know if their pH is getting better? How will you know? You cannot. I know you can clinically correlate that with your patient presentation number. But believe me, stuff are good. In fact, imagine patients that are being sedated. They are intubated. They intubate them. They sedate them, and now they are being ventilated. Intubated, sedated, and ventilated. Now they are not even they are unresponsive. So you need to be doing series of ABGs. If you are doing stuff with them, you need to be doing series of ABGs with them to be seeing how they are doing well, if they are doing well, if they are getting worse. And again, by the time they start winning their sedation, what do you call it now? Their propofols or whatever medication they are using to sedate them, or their paralytic agents, all those things. By the time they start winning them, by the time they start getting bit conscious and everything, you correlate, you need ABGs again to know how they are doing. So that is why we need us. We need us to be able to support our people. We need us. See, there is no one, how do they normally say that thing? There is no one that is an island of knowledge when it comes to patient care. I need you, you need me. I will prompt you, you will prompt me. We need that good relationship. And again, as a physician, we need to also develop our skill set, our knowledge. Believe me, a lot of stuff has gone beyond using therapeutic exercise, therapeutic, to be teaching students. We need people that are doing some certain things to be able to come on board, to be able to relate patient care, how it is being done. This is what you check. This is what we need, those things, not just doing classroom teaching. Oh, because we want to pass exam, cram this thing and go and pass. So how will you, and now when it now comes to patient, how are you going to treat your patient? How will you communicate with MDT? We need reality stuff, not textbook stuff now. That makes sense to somebody. God will help us. I know we are there, we are on the right path, and I know we are doing our best. We are doing everything we can to support our patient. But believe me, healthcare system is a dynamic environment. We just need to keep learning, keep reflecting, to keep doing that clinical audit. We need to keep doing it. So that is that about that. Yeah, somebody talk about base excess. Yeah, base excess, we can correlate that. We can correlate that to every question that we have answered as well. That's it. So I think that's it. Let me just speak briefly on this question that we've got here. We've got this lady on surgical ward. They've got recent surgery. Again,
Okay.
what? Oh, yeah, you wanted to say something? Hello? Hello, ma? Okay. So you've got that patient on
I wanted
general
to add
surgery.
something.
Okay, go ahead. Go ahead.
So just related to these patients and that is just coming and post-op, the hypoxemia could also be related to the pain that the patient is having. I mean, it's an abdominal surgery. And also it could come that the patient is having decreased lung expansion and diaphragm is not doing much work. So there is also reduced lung expansion, which is also correlating to the hypoxemia the patient is having. Just to add that.
Okay, thank you. But I was about saying that. That's perfect, 100%. Everything patient presentations. Somebody have had cholecystectomy. What does that mean? The first place you are reading the case note. Even if you don't know it, bring out your phone, Google it. Nobody expects. You don't expect me to know everything. I don't expect you to know everything. What matters is that my skill set. Do that thing for that patient and let them get better. That little knowledge, that little thing you want to do, that's what matters. It's not the jargons. It's not that thing. This is not exam. They are not texting anything. Bring out your phone, Google it. What does it mean? Oh, cholecystectomy. They've got bladder surgeries. Maybe got bladder removal. Of course, cystectomy means bladder, something like that. They've got gallbladder removal. Oh, so in this patient, 2 days, 1 day, what do you expect? You expect somebody to be in pain. Generally speaking, in advanced countries and over the world, you find this surgery is just generally laparoscopic surgeries, keyhole surgeries. Surgery is just 2 CO surgeries, minimally invasive surgery. Even with that minimally invasive, patient will still be in pain. You will find them, they will be on PCA, they will pressing button every 5 minutes, 5 to 10 minutes or so for pain medications and stuff like that. So all these kind of patients, they will be in pain. But again, generally speaking, they should be fine, generally. But again, that does not mean some people after that minor surgery, again, they will still get chest complications, they will still be, get vascular complications and everything. So now, relate, what comes to, 2 days surgery, they might be in pain, they might, because of the abdominal surgery they have, We don't even know again. The fact that I've said gallbladder surgery is usually KO surgery. It does not still mean maybe in the operation room now. Oh, they might even convert some of them. There are some of them that if they say, oh, maybe things are not going as expected, they can still convert it to open surgery, open abdominal surgery. It could be the case of this person. Yeah. So the plan is to they started with KO and they later converted it to laparectomy, open abdominal surgery. Oh, this person is in pain now at the moment. Okay. Now, what else do you want to relate? Oh, well, check their oxygen. They are on room here, 21%. That's fine, good for them. Oh, what is their PO2? 7. Oh. And you say, oh, because you expect that to be around maybe 10 to 14, but now it's 7. That means their O2 is low, right? What do you want to do? Stick them on oxygen, blast them on oxygen. I want to start with 2 liters, 3 liters, blah, 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 all these kind of things. That's fine. Because if you know if that keep dropping down, this type 1 respiratory failure, oxygen will kill this person. Blast them on oxygen. 2 liters, if this is not, pop that probe. Because you don't want, it's not, ABG is not something you want to do every minute. Why every minute? No. Pop them on probe, see how their saturation is. If you are not happy with 2 liters, they are not saturating well, increase the oxygen, 4 liters, they are not saturating, ventilate, like that. You think in that lane, like that way. And again, why is this special? Well, and again, could we actually reason why they are also not maintaining saturation on pneumonia? Could it be that they have abdominal surgeries, they are not being able to take in breath, they are not being able to take in deep breath because of that pain, because they are struggling with pain? Could that be the reasons? Could it be now because they are not being able to take in deep breath, they are retaining secretions in their chest, that is affecting their VQ, that is causing VQ mismatching? You start relating stuff. There is no direct way. Patient can be presented in any form. Start relating stuff to make your informed decisions. For example, now if somebody has VQ mismatching, I might go to their bedside and stick them on oxygen, start doing chest stuff with them, or get them out of there if they are able. Things like that. So, and again, think about some other things. You also could go to their bedside. Somebody is complaining, I'm having chest pain. I'm having chest pain. Their heart rate is high. Their breathing is very high. And again, you are thinking about chest pain. They are short of breath. Chest pain. Oh, you might want to start getting worried. Oh, what could that be? Could it be? This is post-op patient. It could be pleural effusions. Maybe that is what is driving the oxygen. That could also be causing pain. It could be pneumothorax. It could be anything. It could even be PE. That's what I'm driving at. That's what I want to remember. It could even be PE. Yeah. So you want to even think, these are clinical things that you might even be let's say day 1 post-op now. And this day 2 actually. Let's say day 1. I go to that. You see them patient. You don't need doctor to prompt you for if you are on general study ward for you to go on the ward and start seeing patients. You should have a screening tools. What are the criteria that I'll be using to see my patient, to see patients? Start screening tools, go on the ward, go and see them. You don't need doctor to send a referral to you to be doing your job. Because they are not trained to be a physio. You don't expect them to know 100% that this must be a physio patient. This is not, no, they are not trained to be a physio. So you, as a physio, you should be able to go on the ward, pick who you want to see, and start seeing them. They are your patient. You've got duty of care to them, if that makes sense. So now, so they might even be PE. Oh, they are complaining of the chest pain. They are short of breath. You can even say, oh, let me auscultate. Let me see what is going on with their breathing stuff. You know, if you are having concern, could it be PE? Could it be? You might want to say, oh, can you speak with the nursing staff? You might want to maybe first of all run ECG, see if there is a change in the ECG or stuff. Or if there is a change, if there is changes in ECG, they might say, oh yeah, let's do CTPA, let's rule out PE. Of course, if that is the case now, you now want to weigh when do you see them after the PE, they are diagnosed of PE or whatever. Think about all of these things. Don't just jump on the ward and start seeing patients. You need good clinical reasonings. And again, because patients, I'm just giving different scenarios. Patient can be presented day 2, day 1 can be presented in different ways. And again, patient on the ward with pain, excess pain as well. Not this one anyway. You might, because they are on PCA, they might start pressing that pain medication often and they might start feeling drowsy. Some of them may start vomiting as well because of that anesthetic agent. Start vomiting and stuff. So these are stuff you see. Anyways, let's keep that. So now we have talked about oxygen now. We are not happy with oxygen. Their pH is there. This pH is slightly high. Why is it high? Will it be because they are in pain, they are hyperventilating or stuff? And if you now look at the CO2, CO2 is down. Then definitely this CO2 is the one driving this pH. And why is this pH low? It could be that maybe this patient is groaning in pain. They are hyperventilating or stuff. And it could be PE stuff. And again, they could also be hyperventilating because they've got low oxygen. It could be the reason. You correlate many things. Okay, you go to their bedside, they are hyperventilating, you know that you get access to their ABG, their PO2 is not fine. What do you want to do? Do you want to leave them? Somebody with PO2 or 7, do you want to leave them? You stick them on oxygen. Stick them on 1 liter, 2 liter, start going high. If you are even not, just start going high. Start teaching them deep breathing exercise because you are worried with their oxygen. If that makes sense. That makes sense. Get the pain under control. Speak with the medical team. Get the pain. Get them pain medications. If they are pain, if they are previous on pain medications, can they optimize the pain is suboptimal? Can they optimize the pain for them? So all those kind of things are what you are. The way patient presentation will determine how you are relating whatever blood you are doing with them and what you will be doing with them. If that makes sense. This is a case of type 1 respiratory failure. If you don't do stuff with them, they're likely to die. And it could also be a case of PE, like I mentioned. It could be anything. Yeah, it's as simple as that. So I hope I've been able to pass few message. I'm sorry, I'm just I'm tired here now, so we need to stop here. So I hope I've been able to pass message. The whole information here is whatever we are doing in the acute hospitals, our patients will be at the center. We need to be able to adapt our reasonings to the way they are presenting. We need to be able to correlate their scan, their blood, their whatever things with them. Your goal is not to adapt your patient to your knowledge. Your goal is to adapt your knowledge to your patient, if that makes sense to us. So they scan everything they've done, read it and interpret it and put it in the context. Relate that with your patient. If that is it. So if there are questions, I'm happy to take them now before we end the meeting. Questions? Question, guys. Let's take questions.
There's a question up here in the message. What's the significance of BE being minus 1 millimole per liter or not being within range?
Oh,
there's a question there.
Okay, yeah. The significance of PE, like I mentioned, is just if PE is, let's say, +5, what it means now is what that means is you have retained bicarb monkeys more than expected. If PE is, let's say, -1, what that means is you have started to lose monkeys bicarb, if that makes sense. So that's just it. You can correlate that. So, and again, BE, not PE, BE, base excess, is just talking about your metabolic activities. Don't forget, monkey, when I was explaining that base excess the other time, I was using monkey, bicarb, metabolic stuff. So it just tells you, oh, yeah, your metabolic, it just talks about your metabolic activities. Oh, if you have too much, plenty monkeys, like +5, +7, that means you have retained, your kidneys are actively working now. They are bringing more bicarb to your blood. They are reabsorbing them from your urine down to your blood. And again, if you are getting -1, what that means is, oh, now you have started to use up those monkeys. You are using those monkeys to mop up the hydrogen, mopping them up. That's what that means. So that's that. Question, guys, questions. I hope I've answered that. Questions. I'm just scrolling to the chat box. If there are questions, I know these are crazy stuff, like too much of biochemistry, abstract stuff or something, but I don't know if I've been able to pass some informations about how we can interpret them. Question, guys, questions, contributions, reflections. What you think you're gonna do better when you see your patient? What you think how you think you're gonna interpret that, or how you think you're gonna pass the message down to your junior colleagues for them to be able to start learning good things and treating patients on the ward, observing deteriorations, how patients are escalating, patients that are deteriorating on time, those kind of things. don't think there is any question. Yeah. Okay, sir. Thanks once again. Okay. Okay. I think this is the convenience time to end today's class. Thank you very much, everyone. Thank you for the opportunity to speak to you guys, and thanks again to our registrars, the organizing committee. I really appreciate all your efforts, and we really appreciate all your effort as a whole. Thank you very much. The moderator, sir.
Thank you very much, sir. Really appreciate your time, your energy. We are very, very grateful, sir. So in the absence of question, I think we can call it a day since there's no other question. So a reminder, the workshop that we're supposed to, the topic that we're supposed to discuss today will be discussed on Saturday, that's on 28th of March, the same time. So the link will be posted before the time for the workshop. So in the absence of question, comments, we appreciate your support and patience. So see you next week. Thank you all.